3, 2, 1. I think we got to here, didn't we? We did mesenteries, didn't we? Yeah, we got to this one right here. Okay, so this is the second lecture on digestion, although we really only spent a few minutes on it the other day, kind of getting started, and we did not record that. So I didn't say anything very exciting about the first 13 slides. But here we go on slide 14. Let's talk about the mesenteries. This is always kind of hard to explain because development is a hard thing for you guys to conceptualize when you haven't had any embryology and you haven't had really any understanding of it. But let's just draw kind of a picture of the body here, and this is just the cells of the body when they're starting out. And let's draw the tube down the middle, which we'll call the GI tract, kind of ran down the middle of you. And of course, it was supported by a mesentery from the dorsal side, but it was also supported by a mesentery from the ventral side. So we had blood vessels going into the bowel from the front up here, the ventral side, and we had blood vessels going in from the back, the dorsal side. And what happened is that most of the ventral one went away. And so when we dissect our kidneys, you're going to see that the mesenteries, which supply the blood and the blood vessels up to the intestine, they all come in through the back. Okay? There's one little remnant of that old ventral mesentery left, and it's called the falciform ligament, or the round ligament up in front. It hooks up to the liver, but it doesn't go down to the intestines at all. So just keep that in mind as you're reading about it. So we have a dorsal mesentery, which keeps us all going today. Our old ventral mesentery pretty much went away. It disappears except for the lesser omentum and the falciform ligament. So we'll point those out in lab for sure. So here's kind of that same picture that I was trying to draw for you. This is more complicated than my picture. Here's the neural tube up here. Here's the intestine. This is the abdominal cavity around here. And the dorsal mesentery persisted. The ventral mesentery pretty much went away. And off we go. Does that make a little bit of sense? I think it'll make better sense as we get the cats and look at them. All right. The lesser omentum is the other portion of the ventral mesentery that persists, and it is a piece of kind of a mesentery that comes in from the front that provides access for the blood vessels and the other structures entering and leaving the liver. So kind of the liver and the stomach have blood vessels running through this lesser omentum, and you will need to be able to identify the lesser omentum on your cats. The falciform ligament is even more ventral, and it helps position the liver, and you'll see it as a little layer of tissue that runs down from the abdominal wall into the liver. Okay? Once again, see it in the lab. The dorsal mesentery, which is on the back side, forms this huge pouch that kind of hangs off the front of the stomach, and I think this is a pretty good thing to remember. It sort of hangs like an apron off of the front side of the stomach and the inferior borders of the stomach, and it has a lot of fat in it. Y'all have probably seen that in your cats already. But it's just this big fatty yellow apron thing, and we have one too. And we used to call it the policeman of the abdomen. It was just kind of not free floating, but it was only attached at the top end. And so if you had appendicitis, the omentum would tend to move down into the right lower quadrant to kind of wall off the appendix from the rest of the abdomen if the appendix was getting sick. If it was diverticulitis, usually when you'd open the abdomen, you'd find that the omentum was stuck down there on your colon, your sigmoid colon down here in the left lower quadrant. And if it was your gallbladder that was inflamed up in the right upper quadrant, the omentum would be stuck up there, trying to wall it off so that if it ruptured, it wouldn't contaminate your whole abdomen. Of course, the fact of the matter is, before there was surgery and wonderful antibiotics, a ruptured appendix was 100% fatal. Ruptured colon from diverticulitis was 100% fatal, and certainly a ruptured gallbladder was also 100% fatal. So all of these diseases, which are now just kind of a minor pain in the neck, and you have to go in the hospital, maybe even stay for a few days, used to kill everybody. I don't know how many of y'all have studied the Lewis and Clark expedition. The Lewis and Clark expedition in 1803, 4, or 5. You know, they left from Independence, Missouri, came up the Missouri River, came all the way out here to Astoria, Oregon, spent the winter, and then went all the way back. They started with, I believe, 15 men, and they only lost one person in the whole trip, which is pretty amazing considering, you know, they traveled almost 5,000 miles. They went through a zillion different Indian territories and so forth. The only person they lost due to ruptured appendicitis, or at least they think that's what it was, because another story that just amazes me every time I think about it. Appendicitis, which is such a common disease now, you know, you get pain in your right lower quadrant, you go get a little operation through a little incision about that long and get your appendix out, no big deal. It was not even described as a disease until 1913. Nobody knew what the appendix was for. Nobody knew what appendicitis was, because the only time they ever operated on anybody was when they were dying of anything, because it was too risky to operate on people before 1913. And so, that's okay. So sure enough, nobody had ever operated on appendicitis before. It was just peritonitis. It was infection was spread throughout the abdomen. That's amazing to me. I think of all the kids that I operated on for appendicitis, and to think that every single one of them would have died a century earlier is kind of amazing, isn't it? So anyway, that adipose tissue in the greater omentum off that apron hanging off the front of the stomach, what does it do? Well, it conforms to the shapes of other organs. It pads and protects the surfaces, provides insulation to reduce heat loss, and stores fat, stores lipids. So what else does that do? The mesentery proper is this thick sheet from the back that comes up and carries the blood and everything to the guts, basically. And it's a pretty thick sheet. You'll see it very nicely in the lab. It holds the bowels, but yet it does allow them to move around a fair amount at the same time. It suspends all but the first 10 inches of the small intestine, which is actually the duodenum. We just need to show it to you in lab for you to kind of understand the mesentery proper. But basically, the mesentery proper is the main piece of mesentery that goes to the entire small intestine and most of the large intestine. We call the large intestine mesentery, we call it the mesocolon. I think I can go over those with a picture a lot faster and make more sense. This is a picture of the abdomen here. Here's where that greater omentum hung from. They've cut it off in this picture, but it kind of is this apron that can hang down as far as the bottom of the abdomen there like that. It's been cut off in this picture. This is the lesser omentum here that used to hook into the front of the abdomen. It was part of the old ventral mesentery. It still supplies this part of the stomach and also the liver. Once again, we'll see that in lab. Here's the mesentery proper down here. It's the mesentery that supplies all of the small intestine, and I always call the mesocolon part of the mesentery. It's the same thing, just a different name. Mesentery supplies the ascending colon. This is the ascending colon over here because it's going up, and then the transverse colon here because it's going across, and then the descending colon over here because it's going down, and then the sigmoid colon because it's shaped like an S over here in the left lower quadrant, and then once it gets to the sigmoid colon, it heads out through the rectum because the rectum means straight, and it's nice and straight heading out. Now they've shortened this in this diagram here. There's normally, 5 times that much small intestine, and indeed the small intestine is much longer than the colon, even though it doesn't look that way in this picture. So here's, if you just disconnected all those guts, took them off, and looked at the mesenteries that were left, this would be the mesentery proper here, this would be the mesocolon, transverse mesocolon, descending mesocolon, sigmoid mesocolon, to the rectum. Rectum goes out of the peritoneal cavity, so we call that retroperitoneal. Right? Remember that word retroperitoneal, behind the peritoneum. And you notice there's 2 other things that are retroperitoneal. One of those is the pancreas here. The pancreas doesn't really live up in the abdomen. Now on the cats it kind of is, and certainly on the rats, if you remember that, it was. But in humans, it's pretty much back there against your backbone, and it is retroperitoneal, as illustrated in that picture right there. Notice also behind the peritoneum is the kidneys. 2 kidneys, and also the very first portion of the duodenum, which is illustrated right here. That's the duodenum you see. It's the first portion of the duodenum and the second portion of the duodenum are retroperitoneal. You should know that. If you look at it through a mid-sagittal view like this, cutting it down through the middle, here's the duodenum that I just mentioned back there, retroperitoneal. Here's the pancreas, it's back there, retroperitoneal. And also the bottom part of the rectum is retroperitoneal. The rectum goes out of the belly cavity to work its way out to the outside here at the anus. So this is the mesentery proper here, which has a bunch of branches sort of that allow all the loops of bowel to be suspended like that. Here's the sigmoid, here's the transverse colon. This thing that hangs down here is the greater omentum. It would look like that if you could take the layers apart. This layer coming back up and that layer going down are pretty well fused, so they're not as easy to separate as it might seem. Let's talk about the wall of the gut. The wall of the gut is pretty much the same all the way through, although every part of the bowel is a little bit different, but they all have these major layers. The mucosa is the inner lining. Okay, it's a mucosal membrane. It's a simple. What kind of epithelium lines the gut? Simple. Columnar, simple columnar, with a whole bunch of goblet cells on the mucosa. The submucosa is kind of the supporting tissues right underneath it that has all the blood vessels and all that jazz in it. Then there's a layer of muscularis on the outside, which is actually 2 layers. It's actually a circular part, round, smooth muscles that go around, and also a longitudinal part that runs lengthwise. I'll explain that to you in a minute. And then the very outside layer of all the loops of bowel is called the serosa. But we have another name for it too that you remember from 231, where we put the pins in it and said, what's the first layer that the pin goes through? And that is the visceral peritoneum. Right. So the serosa is the visceral peritoneum in the abdomen. Here's kind of a nice picture of that. This is a piece of small intestine right here. Notice there's a bunch of folds in it on the inside. Those are called plicae circulares. That's just to make more surface area, because remember, everything you eat has got to be absorbed through this mucosa here, and so the more mucosa you have, the better. You got more room to absorb stuff through. So you have these plicae circulares, which are then covered with all these big villi on the outside of it. Here's the submucosa extending up in there. This is where all the blood vessels, of course, come up and down through it. Because remember, epithelial tissue is always avascular. Remember? And so all the blood vessels are down here in the submucosa. This thing here is a gland. There's lots of glands in here that make mucus and make water. The green tubes illustrated here are lymph ducts that help pick up fat out of your intestine, also help pick up extra fluid. And then here's the two layers of the muscularis externa here. And these are smooth muscle, right? Not skeletal muscle, not cardiac muscle, smooth muscle, spindle-shaped cells, one nucleus per cell, in the middle of the cells, so forth. Notice that the inner layer is the circular layer, so it goes this way. So see, it's illustrated here. The inner layer is circular, the outer layer is longitudinal, and all the fibers are oriented longitudinally. We're going to talk about why that's oriented like that, because that's what helps not only mix up your food, but also helps you propel things with peristalsis, push them on down the stream as your food passes through your intestinal system. On this picture here, this is kind of nice because it illustrates the mesentery here with the blood vessels coming in to them from the backside. So the mucosa is the inner lining of the digestive tract. It's a mucous membrane. It secretes a lot of mucus. It's moistened. It's slippery. It's not watery. It's thick. Enough said. The mucosal epithelium is either simple or stratified. The only place that it's stratified is in the mouth and the pharynx and the esophagus. Why is that? Well, when you first put stuff in your mouth, it hasn't been digested at all, so it can have sharp edges and things, and so you don't want it to scrape the inner linings of your bowel. And because you don't want it scraping things, there are significant mechanical stresses there, so it's lined by stratified squamous epithelium. Now, remember, stratified squamous epithelium is what skin is, right? But the difference in skin and this is that this is not cornified. It's not full of keratin. Remember, keratin is that protein that your skin cells make a lot of. That's what keeps your skin dry and leathery. So it's pretty tough. Yeah?
So yesterday I was listening to the lecture and we were talking about the mucosa. So
Yeah.
last lecture my sister was like, is that why magicians could put a sword in without hurting? Is it? And
No, I think that's just because magicians have figured out how to straighten out their esophagus and get it all lined up just right.
I thought it was because
It
of that.
has to do with the way they hold their head and neck, really. Yeah. Good question, though. So once it gets down, it's stratified squamous down to the bottom of the esophagus. And right at the bottom of the esophagus, at what we call the GE junction, the gastroesophageal junction, it changes. It becomes simple columnar epithelium with mucus glands, and it continues as simple columnar all the way through until the anus, right, the very last little inch or two of your butt. The digestive endothelium, one of the other things it has is that it has lots of these endocrine cells. They call them enteroendocrine. Entero means intestine, obviously, and endocrine means that they make hormones, right? What's the real definition of an endocrine gland?
It secretes onto an epithelial surface.
No. Endocrine.
I'm sorry.
No ducts.
Exocrine.
No ducts. That's right. Endocrine means no ducts. Exocrine has ducts.
That's
Okay.
what I meant.
So these are all. A lot of these cells here are scattered amongst the digestive epithelium, and they just make hormones that then circulate around in you. A lot of these hormones, we'll talk about some of them. They help coordinate the activities of our digestive tract. I'll get back to them. So there's lots of folding that goes on. There's longitudinal folds, and then there's these permanent transverse folds that I showed you in before. Now the longitudinal folds, the main place I think of them is in the stomach, because when we used to go into the stomach with the endoscope, it's got a bright light on it, and it's got air, and it's got suction on it. So you'd go out of the esophagus, and of course the esophagus is always kind of squeezing down around the end of your endoscope. And once you got into the stomach, it was still kind of collapsed down because it was empty. We hadn't had the patients eat anything for a few hours. But then you'd start putting some air in the stomach, and as you would expand it with a little air, you would see these longitudinal ridges of extra mucosa. And then as you filled it completely up with air, you could fill the stomach up, so it was big as a football practically, and then look around in it really easy because it's wide open. But those longitudinal folds will disappear as the intestine fills up. The lamina propria is that little submucosal area that I just mentioned to you. It has areolar tissue, contains blood vessels, nerves, lymphatics, smooth muscle cells, scattered areas of lymphoid tissue. Remember that. We're going to find that there's certain areas of the small intestine especially that have huge collections of lymph nodes, lymph tissue in the wall of the intestine. And you'd have to think, wouldn't you, that of all the places it would be nice to have infection fighters, it would be nice in your intestine because it's a pretty thin membrane there between what's inside of you and what's outside of you, right? Because remember, the stuff that's in your intestine really isn't part of you yet. So it's a good place to have that, and we'll talk about that more when we get to it. The muscularis mucosa is this very narrow band of smooth muscle that's right up there in the lamina propria. It's so small, it's just not a big deal. Remember, the muscularis mucosa is very, very thin. We didn't really usually sew it together. There was nothing to sew the muscularis mucosa. When you were sewing two loops of intestine back together, you didn't sew the muscularis mucosa. There just wasn't enough to it. You would sew the muscular layers out here, the outer layers, but not these inner layers. Let me go back to that. Yeah, I think I've said it. Submucosa, right below the mucosa. It's a layer of dense irregular tissue. Surrounds the muscularis mucosa. Remember that muscularis mucosa is incredibly thin. I'm not even sure why we talk about it much. It has some good blood vessels in it, lymph vessels, and this is where the exocrine glands may live. The exocrine glands of your intestine are things like the acid glands of your stomach. Your stomach, makes a lot of acid. We have a pH of about 1 or 2 in our stomach. That's pretty darn acidic, isn't it? And so keep that in mind. Then below the submucosa, there's this little thing called the plexus of Meissner, which basically is a nerve, a bunch of little nerves in there that help coordinate the squeezing of the muscles and so forth. Once again, I don't think you'll see that hardly under your microscopes at all. It's also very small. There are some parasympathetic ganglionic neurons in there and some sympathetic postganglionic fibers. Where do the sympathetic postganglionic fibers come from? Remember that? From the sympathetic chain ganglion, that's right. Remember, the parasympathetic have the long fibers that go all the way to the organs themselves. The sympathetics have short presynaptic junctions that go right to the sympathetic chain ganglion alongside the spinal cord, and then they send out the long fibers down there. So those are the sympathetic ones. All you're seeing is some postganglionic fibers. The sympathetic, the parasympathetics, you're seeing some little ganglionic neurons down there, because that's where the ganglionic, that's where the last synapse is going to occur. The muscularis externa is really the only muscle layer that's big enough for you to see, and it is divided into two parts, as I already showed you, the inner circular layer and the outer longitudinal layer. Now think about your intestine as this long pipe like this, and the way we push stuff down the pipe is by peristalsis. That's the name of the thing. So this piece of intestine squeezes, then this piece, then this piece, then this piece, then this piece, and that pushes the contents of your intestine on downstream. That's what accounts for the gurgling in your stomach when you're laying in bed late at night and you ate a big meal or something. These muscles are involved in two things. One of it is the movement of things down the stream, like I just indicated, but it's also involved in the mechanical processing of the food. In other words, it's got to get mixed up and softened and wet, really wet. And most of that has already happened up in the stomach, but once it starts down the intestine, we do a lot of this. This squeezes, and then this squeezes, and then this squeezes, and then this squeezes. And basically what that's doing is just moving the fluid in your intestines back and forth, so that the juice that's in it's in the middle of the gut is constantly being exposed to different parts of the mucosa where it can absorb the stuff out of it. And it's a pretty efficient system because, you know, if you eat some carbohydrates, it's 100% absorbed by the time it gets through you. So this mechanical processing and movement, sloshing things back and forth is also very effective. Now these movements are coordinated by this enteric nervous system. I think this is a very nebulous thing. There's not any anatomy to this. You can't really see where the neurons or where the ganglions are or anything. Just know that it's kind of all works together, and all these nerves kind of work together to make the stuff move back and forth, mainly down through the intestine. I would just leave it at that. Most of our guts run on the parasympathetic nervous system. Remember, rest and digest, parasympathetic. So sure enough, most of the ENS, this nervous system of the gut, is primarily parasympathetic. There are some sympathetic fibers, but not much. Obviously, sympathetic fibers are going to make the bowels stop, right? Fight or flight. We don't want to be chasing a tiger and digesting our food at the same time. We want to save all our energy to fight or flight the tiger, right? All right, I'm going to leave that as it is. The serosa is the outside covering. It's really the toughest layer. There's a couple of places that don't have a serosa, though. Why would they not have a serosa? The only reason to not have a serosa is if you don't live in the abdomen. If you don't live in the peritoneal cavity and you don't have that layer of peritoneum over you. So what pieces of the bowel don't have an peritoneum over them? Well, basically, it's your mouth, it's your pharynx, it's your esophagus. Your esophagus is running through your chest, right? Not through the pleura, but through the back of the mediastinum back there. There is no serosa to it. And then the last little part of the rectum, as it's heading out of you, it also does not have a serosa. Okay, so keep that in mind. You have serosa basically from the start of the stomach to almost till the end of the rectum.
And the rectum is because it's a retroperitoneum.
Correct, because it's outside of the abdomen, right. Where you don't have serosa, you have this stuff called adventitia. And that's a word you ought to know. Adventitia is nothing but a very dense sheath of collagen fibers. It's a loose, I want to say it's a loose connective tissue, but it's really so much more than that. It's more like a dense connective tissue on the outside of the esophagus and those other organs that we just mentioned. So how do things going down the bowel, I think I've told you everything you need to know about this already. There's this visceral smooth muscle, which is somewhat organized together and helps push things on down. It's kind of a spontaneous depolarization that goes. Your brain doesn't send messages like a pacemaker. Says, okay, contract a little more, that sort of thing. A lot of it is pretty much just rhythmic contraction. Pacemaker cells or pace setter cells, I don't know what they are. I don't know where they're found. Obviously, they're found in the layers of the muscle, but I think that's malarkey. Peristalsis is this system of pushing a bolus of food on down the stream. I think I have a couple of pictures here. Peristalsis consists of these waves of muscular contractions that move a bolus of food or bolus of intestinal contents on down the length of the small intestine. How does it work? I'm going to illustrate that to you with my fingers. Let's do it like this. So here is a piece of intestine illustrated here, and you notice there are two layers. The outer layer is the longitudinal layer, and the inner layer is the circular layer. The circular layer is going around the bowel this way, right? And longitudinal areas are going long like that. So the way that peristalsis works is that the inner layer, the circular layers, contract, and they make the bowel get smaller. And then what happens is the longitudinal layers contract and basically pulls the outer layer in the opposite direction. So it pulls that way, and then the inner circular layer contracts here, contracts there, contracts there, contracts there, and gradually this little bolus or piece of stool or whatever you want to call it gets pushed on downstream. Now, what this is really describing is movements in the small intestine. And just so you know, the small intestine never has solid stuff in it, like this. They're kind of showing you this just for illustration purposes. The small intestine is pure water, basically, in the small intestine. It's not until the fluid gets out of the small intestine, gets into the colon, and stays there a day or so and gets all the water reabsorbed out of it that it turns solid and starts to look like stool. Never thought about that. What is it that controls this? Well, a lot of it is controlled by these hormones that are released by the bowel along the different way. And there's these smooth muscle contraction, kind of self-pacing kind of fibers that work in the wall of the bowel. You guys have all been in the situation where you've gotten really nervous about something, and you're thinking, oh man, I'm worried about this, I'm worried about that, and suddenly you just got to get up and run to the bathroom, and if you don't get there pretty quick, things are coming out, whether you want them to or not. Well, that's what's going on right here. That's what we're talking about. So our brains, our nervous energy can control this, but most of it is controlled by just these kind of natural, in the moment kind of things, these reflexes. Let's talk about some reflexes, because we do have some that really do make this work. I'm not going to go into them in depth here. There's at least 18 hormones that are in your bowel that cause you to move things along faster or move them along slower or cause more acid to be secreted or cause more bile to be secreted or whatever. I am not going to make you learn 18 peptide hormones in the bowel. I am going to make you learn about 5 of them, I think. I think the number's 5. This is just a generalized diagram that shows things like these long reflexes that are related to stretching. If your bowel stretches because you got a bunch of food in it, then obviously it's going to propel things on downstream and work it on through to get it absorbed. Peristalsis, remember, is going to be controlled by the outer longitudinal layer and the inner circular layer of the externa, mucosa, and the muscularis externa. by the way, I didn't ever show you a picture of that muscularis mucosa. The muscularis mucosa, that really thin layer of muscle I mentioned. This is it right here. This is the tiny little thin layer that runs right along underneath the mucosa there. So that's one way that it's controlled by the brain, CNS up there. But then there's also some of this stimulates some of these secretory cells that then, and the pH inside the bowel can cause the release of some other hormones that can cause the release of other things in the bowel. And these enteroendocrine cells that I mentioned, all of those things working together control the passage of things through your intestine. I hope that makes some sense, but please don't worry about it in too much detail.
I
Yeah.
have a question. So, for ulcerative colitis and Crohn's disease,
Mhm.
what exactly is getting attacked? Is it the bacteria or the cells, lymphatic system, or do they really know?
Well, UC, ulcerative colitis, is strictly a mucosal disease, and ulcers form on the inner lining of the colon only. It does not occur in the small intestine. The other one, which is Crohn's disease, is or regional enteritis. It can affect both the colon and the small intestine. And we think they both have a autoimmune part to them, so that it's basically your body attacking your body,
Right.
and that's why they're treated with steroids a lot to cause you to quit fighting your own body so much. They're very difficult diseases to deal with. And I think there's new medicines coming out for both of them that are getting better and better, but they've really been a boogaboo, been a tough problem. Let's talk about, now we're going to go through the whole system from top to bottom, step by step. The comments that I've been making have been very general in nature. And now we're going to go through the different areas of the bowel a little more carefully. Let's start with the mouth and think about what happens when you put something in your mouth. Well, the first thing is you feel it. The second thing is you taste it. And there's probably lots of stuff in your life you've put in your mouth and you spit out almost reflexly. Sometimes it's so bad you just got to get it out of there instantly. Well, that's pretty important, isn't it? Because those probably are not the sort of things you want to be swallowing. We then chew it up. We mash it back and forth. Our tongue moves it from side to side. Our palate works on it to move it around. And in the process, it gets lubricated. It mixes with mucus and the spit glands, the salivary glands, which we'll talk about in just a minute. There is some digestion. Some of the actual breakdown of carbohydrates and lipids happens in your mouth. I think I told the story about the saltine cracker the other day. You put a saltine cracker in your mouth, and let it sit there and just chomp it up and let it sit there moist and mix with the spit in your mouth. In 5 minutes, it'll taste rather sweet, and that's because the starch, which is what a cracker is, gets broken down into glucose, and then it tastes sweet. The lining of your oral mucosa is important. It has to have a little protection, so it's stratified squamous epithelium. But there are parts in your mouth that are very thin, and they're non-keratinized, so they're not tough, very delicate. Inferior to the tongue is the most thin in your mouth. If you've taken your tongue and pulled it over to the side and looked at it in the mirror up close, you'll see just how thin the mucosa is on the undersurface. You can see blood vessels and everything right through the mucosa underneath there. That's also really important because we have learned to give a lot of drugs sublingually. SL means sublingual. People have heart pain, angina. They take a nitroglycerin, put it under their tongue, and the drug gets absorbed right through the mucosa of the underneath the tongue. Our cheeks have little pads of fat in them, and the buccinator muscles are the chewing muscles that we have out there as well. You remember those guys, don't you? The labia are called the lips. The lips, these lips right here. And basically, you have to remember that we have mucosa on the inside of our mouth, and when we have this little strip of tissue that you have to put chapstick on, right, to keep your lips from chapping in the winter, and then it becomes skin, right? So it's kind of three different mucosas right there touching each other. Never thought about that, did you? Has anybody ever put chapstick out here on your face? Not really.
My kids.
There you go. The vestibule is this place between your cheeks and gums where idiots put chewing tobacco. It's called the vestibule. You know, I've spoken against cigarette smoking a lot in this class, but I will tell you that 4 times worse than cigarette smoking is chewing tobacco. It puts the level of nicotine in your blood 4 times higher. Therefore, it's actually 4 times more addictive than smoking cigarettes. Chewing tobacco is the hardest thing in the world to quit. It's much harder than cocaine or heroin or anything. Because the level of nicotine you get in your body is just so high. I always thought it was an incredible experiment. Somebody decided one day to put a bowl of cocaine in a rat's cage, a bunch of rats' cages. It was a controlled experiment. And the rats would eat the cocaine until they got really high, but then they would stop. But if you gave them nicotine and put nicotine in a bowl, they would eat nicotine until they were dead. So nicotine is incredibly addictive, and when you get it, you just want more, and you'll take it till you're dead if you're a rat. And I think most humans would probably stop before that, but I don't know. I really don't. Plus, it's so damn gross. Ugh. Anyway, your gums are these things in your mouth that hold all your teeth. They surround the base of each of your tooth. It's called the maxillary bones. Is the bone that your upper teeth plug into, and your mandible is the bones that your lower teeth plug into. I have 2 teeth right here that are dental implants. These 2 teeth were knocked out of me one time when I was in the Navy, and they actually put them back in my head, and they lived about 10 years. They told me they'd probably only live about a year, but they lived about 10 years, and then they fell out, and I got these metal screws screwed way up into my maxilla, and then to those metal screws, once they healed in, then they screwed the tooth on. So these are both fake teeth in front, and they've lasted now for almost 20 years. So probably die with them. Hope I do.
Did they do a root canal on your teeth when they put them
Yeah.
back in?
Both of them.
Because I had this one and this one knocked out, and I've had them for 12 years.
Yeah.
No, by 18 years. But they did a root canal on both of them. But that's their fear, that they'll fall out, or they'll get disease.
Yeah. Well, that's what happened to mine. They lasted a lot of years, and then they came out, and then I had to have implants. But implant surgery was pretty new when I got it, which was 1990, 92, 93. Now, you've seen these ads on TV for One Choice or Clear Choice, where they'll actually jerk all your teeth out one day, go in and put all these implants up in there and screw all your teeth in all in one day and give you a new set of teeth. It's just amazing to me what they can do. Because they have these magic CAT scans that tell, scan your jaw and make sure you've got enough bone, because you have to have enough bone to screw the screws down into and screw the screws up into, and so forth. It's pretty wild.
Whereas a porcelain crown takes 2 weeks. I just lost a crown, and it's going to take 2 weeks to replace it.
Yeah.
There are places that have like the lab in the place.
Right.
I know. They're a lot more expensive.
Oh,
Oh yeah.
it's true.
moving along here. So this is your little vestibule down here. The gingiva is your gums. That's what that word means. Your upper lip, and there's your lower lip. These are all the muscles of your tongue. Remember, they're all controlled by what nerve? What cranial nerve controls the tongue? Number hypoglossal. Number
Hold on.
12. On Old Eleventh is towering tops. Finn and German viewed some hops. H, hypoglossal. Okay, so there's your tongue. Here's your palatine tonsil. If you've never looked at your palatine tonsils, you should. You can always see them if you just stick your tongue out a little bit. Please notice that here's your lingual tonsil down here, which is a tonsil that's actually kind of on your tongue itself.
And you remove that.
I think I'll leave it at that.
They remove that one with the total.
With a TNA, tonsillectomy and adenoidectomy. Yeah, there's one more tonsil that's kind of right up in here called a pharyngeal tonsil that I don't have listed on this picture here. It's on the model.
And there's all three of those.
It's on the top.
Which is-
Yeah, here it is. This is the adenoid. This is the pharyngeal tonsil up here.
Which one is the palatine tonsil? Is the one that's usually removed, correct?
That's the one you see. Yeah. Well, I don't know. You always get a T and A. You get a tonsillectomy and adenoidectomy.
I do.
So you get a T and A.
Oh, and so they just leave the lingual.
And you thought T and A was something else.
It is.
So yeah, here's your palatine tonsil that you can see in your mouth. It's just to the side of your uvula. There you go.
Are the lingual tonsils ever removed, or?
I don't think so. I don't remember ever hearing of that being done. It's a good question though. They don't interfere with the airway like these other guys do. The pharyngeal tonsils really, I know Josie, my granddaughter, had, she was having 2 or 3 episodes of tonsillitis a year, and we took her in, and I remember the dentist takes an oral surgeon who takes a little tiny bronchoscope and looks back in her throat, and then he kind of twists it to go up and look at her adenoids, and he could see it and see how big it was. And it was really kind of blocking her airway. She was a very noisy breather. She snored all the time. She didn't sleep well during the night, and she kept getting all this recurrent tonsillitis. So he recommends she get her tonsils out, and it's made a new kid out of her. I mean, she sleeps. She doesn't snore. She's the fastest runner in Washington County.
And I'm guessing the sleep is more restful.
Oh, I'm sure it is, yeah. As opposed to my buddy that I went to the duck game with. Oh, you missed that. You won't forget it, will you? Sleep apnea is bad stuff. A couple more things that we haven't talked about yet is this little thing down here called the lingual frenulum. That's the little thing that holds your tongue down. Kids that are tongue-tied have a real overgrown lingual frenulum, and you just kind of go in surgery and just clip it and loosens it up. They don't have their tongue tied to the bottom of their mouth any longer. And please notice, and you can see these on yourself too, if you look in the mirror with a bright light tonight, you can see the 2 openings on either side of your lingual frenulum right there, which is the openings of the submandibular glands. The submandibular glands live right down here. They're 2 of your spit glands, and they come up and dump out right there. That's the 2 that gleek, that will spit on you every now and then. We'll talk about them in a few minutes, I think. What does the tongue do? Well, it moves everything around. It's such an amazing organ, and I'll just leave it at that. But, we can chew if you take a bite of steak in your mouth and you chew it 6 or 8 times, you've probably got it completely broken down, because your tongue is so sensitive, it can assess which parts of that bite still have some tough stuff in it. Your tongue will move that piece of meat around one way or the other so that it's all chewed up really well. I just think it's amazing. Obviously, it measures the touch, the temperature, and taste of everything that you put in your mouth, which is important too. You do have some lingual lipase. Lingual lipase means basically tongue lipase. Lipase means it's an enzyme that breaks down fat, lipids, right. So we're going to be talking about a number of proteases and lipases and so forth as we go through the digestive tract here, but that's one of the first ones up here. The salivary glands, there are three pairs of them. Please do not feel like you have to memorize the differences in their properties, but you should know where each of them are and how they empty into your mouth. The first one is the parotid salivary glands. The parotid salivary glands live right here, and if you've ever had the mumps, that's where the mumps got its name from. It's a virus that used to infect people's parotid glands. Now it's hardly ever seen anymore because it's in the MMR, mumps, measles, rubella, and people don't get it. But it's a pretty big gland right here in your cheek, and the duct, it's an exocrine gland, so it's got a duct, and that duct goes through your cheek and comes right out here to the side of your mouth, and right alongside one of your molars back there, it empties into your mouth, right about there. Now, once in a while, people will used to come into the office and with pain in their parotid, and it was all swollen up, and they would form stones in that duct. And you could actually take their mouth and go like this and look in there, and you could actually see the stone right as it was trying to get out of the Stenson's duct. Stenson's duct is the name of the duct right there. It empties into the vestibule here beside the second molar. That's what I should say too. It's along the second molar. So it's right there, and you just kind of take a needle and knock that stone out, and then there's this outpouring of all this spit that comes out of their parotid gland, and they're all better very quickly. It's kind of a nice cure. People who get stones form in their salivary ducts, we usually just gave them hard candy, which makes you make more spit, and as long as you're making enough spit, then you don't form stones. So we would just tell them to suck on a peppermint or something every day, and that would pretty well take care of it. The second set of parotid glands is the sublingual salivary glands. Now these are very small. Sublingual means below the tongue, and if you go home tonight and kind of hold your tongue out to one side and look right there through that thin mucosa on the bottom of your tongue, you can actually see the glandular tissue right there under the mucosa. And these glands are pretty small, and it has these little things called Renvious ducts or rivinous ducts, sublingual ducts, and there's a whole bunch of holes on either side of the lingual frenulum. They're just 8 or 10 holes on either side. So these aren't the ones you gleek through. The sublingual salivary glands are not the ones you gleek with, but they do empty out right there along either side of the lingual frenulum in your mouth. The last third set is called the submandibular salivary glands, and just like it says, they're below the mandible down here. And I had a few patients that developed a tumor in their submandibular gland. We would operate on them through their neck down here and go in and take that one out. They sort of appear in the forward of the mouth, but really you see them right here. They make a lot of spit. These are the ones that have a single opening on either side, right behind the teeth, right here in front. These are the ones that you spit through, gleek through. They're called Wharton's ducts, but I don't care about that name. Just know they're from the submandibular gland, and they're called the submandibular ducts. As far as how much spit do you make a day? We make quite a lot, about 1.5 quarts of spit every day. I don't care if you memorize these numbers here, but most of it comes from the submandibular ones, the ones down here in your throat. The parotids, even though they're pretty good size up here, only make about a total of about 25%, and then just a tiny amount is made by those sublingual ones right under the tongue. So here's a nice picture of all 3 of them. Here's the parotid gland up here in your cheek. Notice the duct runs through your cheek and then empties in right alongside your second molar into your mouth. Here's the sublingual ones, the little tiny ones, and they dump out through a whole bunch of holes along the lingual frenulum there. And then here's the submandibular ones down here in your jaw, and they come up and drain out through the duct up here in front, which really isn't illustrated there very well. Or is it? I guess this is it. They're illustrating it right here, but it dumps out right up there in front. What is saliva? Pure water almost. 99.4% water. There's a little bit of electrolytes in it. There's a little bit of enzymes. The enzyme is mainly amylase. Amylase is breaks down carbohydrates. And I think that's enough. You know, as far as mumps is concerned, y'all probably don't even know anybody that's ever had mumps. Does anybody know anybody that's had mumps?
My mom.
Your mom did? I can tell you, as a general surgeon, I got the job of deciding whether a lot of men had a hernia or not, and examining their testicles and examining them down there. And I would say once a week, I would evaluate somebody who had a really shrunken up testicle on one side or the other. Sometimes both of their testicles were just the size of marbles. And I would always ask them, I say, what happened to your testicle? And they say, oh, I had the mumps. And that was the problem with the mumps, is yeah, it would affect you up here, and these glands would get big and swollen. But in most guys, in young boys, it would go down to their testicles, and their testicle would get all inflamed and swollen and get big and big and big, and then it would shrivel up and go away. And it was worthless to them.
So it could cause it sterilized them?
If it was involved both testicles.
Yeah.
If it just involved one, it didn't sterilize them. The problem is they had to go in the locker room when they got to like the 7th grade, and boys are terrible, you know. Hey, how you doing, one hung low, you know? And so what we would do is operate on them and put in a fake testicle in the other half of their scrotum, because they had nothing on that one side. If you catch it early when it's as a kid's going into puberty and stuff, you put in a fake testicle. And then sometimes you have to bring them back 5 years later and put in a bigger one as they grow up. But it's a big deal. And mumps, you know, it just kills me. You know, we have all these anti-vaxxers now, you know, that don't believe in vaccinations. And the reason they don't believe in the vaccinations is because they've never heard of or seen the diseases. But these were not good diseases. They were bad diseases. People got really sick from the mumps. It sterilized a lot of people. And I saw it every week. I mean, I really did. So it's nothing to be taken lightly. Anyway, what does saliva do? It lubricates your mouth, makes spit, allows you to spit things. It dissolves some chemicals, has your taste buds, remember they're right there in your mouth. Here's the salivary amylase, which is the first one that starts digesting the complex carbohydrates like that saltine cracker I mentioned. What controls your salivary secretions? Same old thing. It's, you know, autonomic. It's mostly parasympathetic. Parasympathetic is going to accelerate your secretions. So if you're in rest or digest, you're going to make a lot more spit. If you're in sympathetic, you're not going to make spit. You're going to save everything to fight the tiger, right? There are little spots in your brains called the salivatory nuclei. They live up in the medulla. So what? Let's not worry too much about how our brain tells us to make spit. Is that fair? Okay. For you dental hygienists in the crowd, this is the 10 minutes of all of A and P that we're gonna talk about the teeth. But the teeth are cool, and believe me, having gone through those two problems with those two teeth of mine, what a pain in the neck that was. It seems like I spent 100 hours in the dental chair for that mess, but anyway, yeah, I'm sure it wasn't that long. Chewing is called mastication. Remember we had some muscles that were called the masticator muscles. Dentin is the matrix of the bone. It does not have cells in it. I'm better off showing you a picture here in a minute. The middle of your teeth is called the pulp cavity, and that's where the blood vessels and nerves go up through the root canal. So when you get a root canal done, what that means is you chisel out all of the inside of your pulp cavity, take all of that out. Basically, it makes your tooth numb, because it's numb, it doesn't hurt anymore, supposedly. And I'll show you what that looks like here in a minute. The bottom of the tooth is called the root, and the root sits down into this little bony socket called an alveolus. We've got a lot of alveoli in our body, don't we? And there's this layer of cementum that kind of cements it down in there. The crown of your tooth is the part you can see. It's the exposed portion of the tooth, and it projects beyond the soft tissue of the gingiva, the gum, gingiva gum. Dentin is covered by enamel. Enamel is the hardest substance known to man, and it's pretty amazing stuff if you think about it. I think we can say that the maxilla has the maxillary arcade, that's your upper teeth, and the mandibular arcade is the lower dental arch on the bottom. Here's what a tooth looks like if you cut it apart. So this is the bone out here. So this would be, if this is a bottom tooth, which it looks like it is. So this would be the bone of the alveolus, the bone of the socket here that accepts the tooth. And for the lower teeth, that would be the mandible. For the upper teeth, it would be the maxilla. Notice that the vessels and the nerves come in from the bottom, come up through this root canal, up into the middle part of the tooth called the pulp cavity. Surrounding the pulp cavity is this material here, which is dentin, which has no cells in it. It's kind of like bone. And then on the outside of that is this layer of cementum that really cements them in place. That's easy enough. This is the enamel, the white up here on top. It's really the tough stuff that is good for a lifetime. It's really, really hard. From there up is called the crown, the neck, and the root. I don't know how important those are. So when I had my root canal, what that means is the dentist goes up here on top, numbs it all up first, drills a hole down here into your pulp cavity, and then he had these little tiny, tiny drill bits that are designed to clean out your pulp, clean everything out here. So all of these nerves and all of these arteries are just kind of ripped out. And he runs it up and down. It's really tiny, and cleans this all out, and then cleans all of this out up here, all of this out here. And then they usually pack it with something to just leave it hollow and empty for the rest of your life. That's what a root canal is. Root canals it's sort of an expensive procedure, I understand. I went to see the dentist one time. I'd been having pain in one of my teeth for about, I don't know, a couple of weeks. It was really hurting me. And I went to see the dentist, and she was this really nice lady, and she said, well, sir, you have a bad tooth there, and you need to have a root canal. I said, really? She says, yeah. I said, yeah, you're just going to have a root canal. I said, okay, thank you. Would you schedule me to see the endodontist? That's what the endodontists are, the guys that operate on the inside of your teeth. They do the root canals. And she set me up for an appointment for about 2 weeks from then. And about 2 days from then, the pain went away. And that was about 12 years ago. I've never had a bit of pain since. So don't go jumping on it real fast if they tell you you need a root canal. Think, maybe I'll just check this out for a few days, and let's see if this doesn't just go away, because it certainly did in my case, and I've not had one bit of pain since. And I'm glad I didn't get a $2,000 root canal done in the meantime. Dental succession is kind of a cool thing. We basically are born with 2 sets of teeth in our mouth. Our baby teeth, which are called our primary dentition, or our deciduous teeth. What's a deciduous tree?
It sheds its leaves.
It's the one that sheds its leaves every year, as opposed to an evergreen, right? Well, these are our deciduous teeth, and they're going to fall out, just like those leaves are going to fall out. Our secondary dentition is our permanent teeth, and they come in and stay in. Deciduous teeth are also called primary teeth, milk teeth, baby teeth. We basically have 20 baby teeth, 5 on each side, 5 up, 5 down on the right and left. Total of 20 baby teeth. I always remember you're supposed to get your first baby tooth when you're 6 months old and get 1 a month after that. That's about the normal progression for babies, if somebody wants to count. So here's what they look like. The ones in back are called molars. The rippers, the teeth that rip things off if we were meat eaters. There are cuspids out here, and then the ones in front are called our incisors. But then we get our permanent teeth. Baby teeth start falling out, and we get 32 permanent teeth. So you have 20 the first time around, you have 32 the second time around. 8 on each side, 2 incisors, 1 cuspid, 5 molars. 5 molars on each side, right and left. Wow. Some of those molars never do even hatch out. We call those wisdom teeth, right? It's usually your posterior molars on each side. I was going through this dental stuff when I was in the Navy, and about the last 2 weeks I was in the Navy, I went over to one of my dental buddies and I said, listen, I've never had my wisdom teeth taken out, and I've been told I should have them out because they're kind of growing, they're in sideways and they're way down deep in there. He says, oh, come on, we'll take them out Thursday. And so I went over and he made me loopy and numbed it all up and took them out, and I spent 2 or 3 days on pain medicine. God, that thing hurt. And then it all got away. So that was my last act in the Navy, really. And that was in 1981. So there you go. There they are. Aren't they beautiful? I love this picture here because this shows you that when you're born, you have both sets of teeth. This is actually a child's skull. And all of these teeth down here you see haven't come out yet. These are your permanent teeth that are actually in your head. And these are all baby teeth that are in place up here, but they're all going to fall out. So this is a young kid who was killed for something, died from something. And they got his skull and made this really cool photograph of it.
So does the area where the teeth are, does that just ossify after they...
Yeah, after they erupt and come out, the area under it ossifies. But remember, they're going to have roots that are going to, the roots are going to develop. And so the roots on molars, are pretty good size. They go down in there pretty well. So, yeah. Mastication is called chewing. The way we chew is we put our occlusal surfaces of our teeth together. Not only do they come down and crush, but they also go sideways and rip and tear to chew up our food. We have some lovely muscles of mastication that both close our jaws and rock our jaw from side to side. And I don't know if you remember these different motions when we were doing flexion, extension, and plantar flexion, dorsiflexion. And we mentioned these, but we said they just have to do with your jaws, and we don't really use them much. Well, here they are. Elevation, depression, protraction is putting your jaw out, your lower jaw out. Retraction is pulling it back in. Medial and lateral movement is back and forth from side to side. So we can really move our jaw around pretty good if we try, but we don't do it all that much. The pharynx is the next, after the mouth comes the pharynx. And the way to remember the pharynx is simply that it's the common passageway for both food and for liquids and for air. So when things go down the wrong pipe, they've gone down the wrong pipe because the pharynx is a communal area where both areas, both systems, both your respiratory system and your digestive system use it. Just to make things more complicated, we divide the pharynx into three parts. The nasopharynx is the nasal part. The oropharynx is basically the back of the mouth. And then the laryngopharynx is a little bit lower, just above the larynx. And obviously food is going to pass in order through the oropharynx and the laryngopharynx. It's never going to go through your nose unless you're snorting milk through your nose or something. But air is going to go through your nasopharynx, your oropharynx, and then your laryngopharynx, right? That makes sense? Y'all get that? The esophagus is a muscular tube. Remember, it doesn't have a serosa, so it just has an adventitia on the outside of it. It starts right up here behind the cricoid cartilage, and it's about 10 inches long. And I'll show you some x-rays. I've got a video of swallowing on x-ray, and you can actually watch somebody swallowing this stuff, and it goes down about this fast. It's done. Food does not stay in your esophagus hardly at all, and then it's in your stomach, and I think we'll leave it at that. The esophagus has a resting muscle tone, and that's why we don't swallow a lot more air than we normally would, is that our esophagus is always kind of clamped down, and that helps so that when we're breathing, which we're doing pretty much all the time, we're not getting any air down into our stomach. Now, we can all swallow air intentionally, and we certainly get some air down in there, but I think I'll just leave it at that. The histology of the esophagus, remember, it does not have a serosa. That's really the only point from this. It does have a mucosa and a submucosa, and it has a muscularis, but it doesn't have a serosa. So it only has 3 layers. The mucosa is keratinized and non-keratinized. In other words, it kind of gets leathery depending on how you eat and what you drink, I guess. It is a stratified squamous. There are large folds that extend the length of the esophagus that kind of point the way for the food down the way, I guess. The muscularis mucosa is that tiny little layer of muscle that, once again, is very small. The submucosa contains a number of esophageal glands, and they make a lot of mucus. You want your esophagus to be very greased up for when you swallow that bite of popcorn or something. Keep it from scraping you and allow it to get on down. Muscularis externa has the usual inner circular and the outer longitudinal layers. So here's a nice picture of the esophagus. The esophagus, you see, goes from here to there, and it has the normal. The outside is the longitudinal area. The inside is the circular area. Muscularis mucosa is right here in a little tiny layer. You really don't see it there. Here's the mucosa. You see it's all kind of folded up, and basically the esophagus stays collapsed pretty much all the time. Notice here that it's stratified squamous. That's what it always is. It's not usually cornified. This almost looks like it's keratinized and cornified a little bit right there, which would look like skin, but just know that your esophagus is pretty tough and it gets beat up from things we swallow. Swallowing is called deglutition. That's a word you ought to know, deglutition. We can voluntarily decide to swallow. Once we start the swallow, everything else proceeds on from that point. So we can initiate a swallow, but once it has started, then it goes on automatically. So if you start it, then not only does your larynx lift up, closes off your esophagus, but this contraction ring starts and pushes everything on down, and you can't stop it. So there's 3 phases to it. One's called the buccal phase. Buccal means cheeks and mouth, yep. The pharyngeal phase is when you push that food into the back of your pharynx, and then it starts down the esophagus, and once it's started down the esophagus, there's no bringing it back unless you can vomit really good. Here's kind of how it works. If this was a blob of food right here called a bolus of food, you notice that our tongue pushes that bolus of food to the back of our throat, and at the same time, it causes the soft palate up here to close off your nasopharynx. This would be nasopharynx up here, right? So because you don't want the food to go back up into your nose, and then your epiglottis, your trachea and larynx are going to push up against the epiglottis here to close this hole off because you don't want it going down this way either. So that's the first phase in the back of the mouth. Then you start to swallow it, you push it back into the pharynx, and by that time you see the epiglottis has closed off the trachea right there, and then it starts down, and once it's started, you can't stop it, and it's one wave of peristalsis goes right on down. Now, one of the important things to understand, which our book really doesn't talk about, but it's amazing because it's probably the most common symptom in all of America, and that is that when we swallow a bite of food, there's a muscle in the lower esophagus called the LES, the lower esophageal sphincter, which I don't think our book even mentions. But that muscle is normally kind of tight because you don't want the acid from in your stomach to wash back up in your esophagus because your stomach, remember, is very acid, and your esophagus isn't really made to have acid in it. So that LES is important that it stay closed. And when you swallow that bite of food, what happens is as the food gets down to about here, the LES opens, food goes through into the stomach, and then it closes back. And you hope that it stays closed all the time. If it doesn't stay closed all the time, it leads to heartburn. Heartburn has nothing to do with your heart, but it sure can burn. But it's basically acid washing back up into your lower esophagus, which can burn the inside of your esophagus and actually can cause you cancer of your lower esophagus. So it's a big deal. Lots of medicines. I remember when I started practicing, we didn't have any very good medicines. All we had was a medicine called Tagamet, which would make your stomach quit making so much acid. And obviously if there wasn't as much acid in the stomach, it didn't hurt as much when it came back up. But then we got another one called Reglan, and finally now we have all these fancy medicines that are just fabulous because not only do they make the acid go away in your stomach, but they increase the pressure in your LES so that food doesn't wash back up there again. And I'm trying to think of the names of a few of them, but I can't.
What's the hiatal hernia? Does that affect the
A hiatal hernia is just a little hernia where your stomach herniates up into your chest. It really is. It doesn't.
Okay.
It doesn't matter if you have a hiatal hernia. The thing that matters is whether or not you have acid reflux, whether you have acid washing back up. I want to stop right here. Let's stop right here at the beginning of the stomach. Okay, here we go. This is the second lecture on the chapter on digestion. Let's talk about the stomach and the rest of the way on down through the GI tract, hopefully. The stomach is a pouch that holds quite a bit. That's why we can eat Christmas dinner or Thanksgiving dinner and put away a quart or two of food. And it sits there in our stomach and kind of gets mushed up and softened and then gradually, very slowly gets pushed out of the stomach and on down into the intestine. So what are the major functions of the stomach itself? They are to store the ingested food so we can eat a big meal at once, which was probably a very important thing in evolutionary times when maybe we didn't have food sitting in the refrigerator all the time. We had to go out and kill something, and then we wanted to eat 2 or 3 days worth of food at once. That's kind of the way it worked. It also breaks down the ingested food So what starts off as a hamburger that you've chewed up two or three times and it's down there, it still looks like a hamburger kind of. It gets mushed up and mixed with acid and digested chemically, and it just looks like dirty water almost by the time it gets pushed out of the stomach. It starts breaking down these chemical bonds. Both the acid that's secreted by the stomach breaks down some of those bonds, and the enzymes that are released. Remember, we started releasing enzymes in our mouth with our spit and our saliva that had amylases in it and so forth. The stomach also makes this thing called intrinsic factor. And you just need to know about this stuff, I have to tell you. Intrinsic factor comes up on every test. And know that intrinsic factor is only made in the stomach, but it really doesn't do anything in the stomach. It simply is made there, and then it mixes, and as it goes on down into the small intestine, it allows your body to absorb vitamin B12. Now, if you don't have any intrinsic factor, and you can't absorb any vitamin B12, we call that pernicious anemia, and people can get very anemic from that. So you need to know intrinsic factor, pernicious anemia, stomach. Now, I have to tell you that in the real world, most of the time, most of the folks who get pernicious anemia have either had their entire stomach removed for tumor surgery or some kind of surgery, one reason or another, so they don't have any stomach to make this stuff, or they have a terrible gastritis, which is a irritation and redness and swelling and dysplasia almost of the wall of the stomach, and they don't make any intrinsic factor. So it's always a real problem with the stomach that leads to pernicious anemia, vitamin B12. I also have to tell you that when I first came to the Dalles, I noticed that there was this family doctor that was in the same building as me, and he was like 80 at the time, and he just wanted to keep practicing medicine, and he had this big stream of old ladies that would come in and visit him every day, and he would talk to them and pat them on the back and check their blood pressure and give them their B12 shots. He gave half of the town a B12 shot. And I don't know what he charged for it. It was probably not all that much, but it was enough to keep them coming back. And it was totally a placebo because people don't really need a bunch of vitamin B12. But he would give it to them, and it'd make them feel better. So he was Dr. Feelgood. And it made him a living. I bet there's probably one person out of 100,000 that is actually B12 deficient. It's a very, very rare problem. Like back in those days, you couldn't measure anybody's B12 level. So why not give them a little if it doesn't hurt anything, huh? It's kind of like HRT, hormone replacement therapy. Because at the same time they would come in and get their B12, he would also renew their estrogen hormones and their female hormones, and that would make them feel better. And their husbands would love it because they were all hyped up and wanted to have sex, I guess. But, you know, we also found out later that we were killing lots and lots of those ladies by giving them extra estrogen. Anyway, we live and learn. Regions of the stomach, I think this is pretty silly. The stomach is kind of shaped like this, and I think our book kind of describes this as the cardia. The cardia is up here closest to the heart, and this is the fundus out here, and the body. Body is all in through here, and then there's the pylorus, which is the distal part of the stomach down here. This is pylorus. Now, the pyloric muscle is this little muscle that's right here in the wall of the pylorus that really controls the food leaving. So it pretty well snaps shut when you eat a big meal, and it stays closed for about 2 hours, and then you gradually start spitting it out into your small intestine. It's very important that you not spit your food out too fast into your small intestine. If you do, that leads to what is called dumping syndrome. Dumping syndrome is when your stomach empties too fast and you get all this high-calorie, high-protein highly concentrated, highly osmotic stuff emptied into your duodenum and going on down your small intestine, and it makes people feel really lousy. It usually gives them really bad diarrhea all of a sudden as well. But anyway, that's the real value of your pylorus. Here's a nice picture of it, better than mine. But this is your cardia up in here, right where your esophagus empties into it. Fundus is out here, body of your stomach out in here, and then the pylorus, or the also called the pyloric antrum, is down here. Pyloric antrum is kind of different, as we're going to learn, because that's the part that makes gastrin, which is a hormone that helps control all of this. This is the lesser curvature over here on this side, for obvious reasons. This is the greater curvature on this side. Now remember, the lesser curvature over here has the lesser omentum attached to it. And remember, the lesser omentum, the stomach used to lay in here like this, and the lesser, or correction, like this, and the lesser omentum used to be part of the ventral mesentery. Remember that? Okay. Not a big deal. It's in embryology kind of thing. The stomach has big rugae, these big folds in the wall of the stomach, which will go away. When we used to endoscope folks, you'd put the scope down in their esophagus, and you'd advance it on down, and then you'd get to the stomach, and the stomach would pretty well be collapsed around your endoscope, and you'd push the little button, and you'd fill it up with air so that you could look around really good. And as you filled it up with air, you could see these rugae just kind of flatten out and go away. And that's really what they're there for. They're there to allow the stomach to really expand in size. The stomach has 3 layers of muscle as opposed to every other part of the intestine, which really just has 2. It has an oblique muscle layer. So it has a circular layer, goes around. It has a longitudinal layer, which runs lengthwise. And the one extra layer that the stomach has is called this oblique layer that runs at an angle. Now the stomach is, what it does is it just sort of sits there and mushes your food and gets it wet and makes a bunch of acid and stuff and enzymes that are mixing with the contents of your stomach as you're starting to digest your food. So the stomach, probably more than any other part of the intestine, just mechanically mixes, moistens, and starts to break down the food. The stomach almost absorbs nothing. Almost nothing is actually absorbed through the wall of the stomach into your body. That all takes place down in the intestine, so keep that in mind. But the stomach does have a very thick lining of mucus, because remember, the stomach is going to have a pH of about 2. It's very acid, hydrochloric acid secreted by the wall of the stomach. And if it weren't for the fact that the entire stomach makes this massive amount of mucus, basically the acid never touches the wall of the stomach, because there is always a really thick layer of slimy mucus on the inside lining of your stomach. And any of those of you who have ever vomited have probably experienced that. You can see it. It's really moist and slimy, and it tastes like hell. It's really acid, and it's just enough to almost make you not drink that much again. Right? Anyway. All right, so I think we've been over everything here. Here's the duodenum. The duodenum starts right after the pyloric sphincter muscle. And I think I'll move on. So the smooth muscle of the wall of the stomach is basically the muscularis mucosa, which is that little tiny, tiny layer of muscle that's right up in the mucosal wall almost, and the big muscularis externa. It's the big, thick layer of muscle on the outside. But remember that it has this extra layer of oblique muscle in addition to the circular layer of muscle on the inside and the longitudinal layer that's outside of that to help mush the food up. The histology of the stomach, looking at the stomach under the microscope, and you all ought to do that, It's always a simple columnar epithelium, which is true of all parts of the intestine from the stomach on down to the anus, really. It's all simple columnar. The esophagus itself is stratified squamous. It's not cornified like your skin, but it's stratified squamous. And so there's some slides over in the lab that you ought to look at. They're called the GE junction slides. GE is the gastroesophageal junction, where the esophagus meets the stomach. And as you're looking at those, you can see that the esophagus end is stratified squamous, and then it just comes to a point, and then boom, it becomes columnar, and that's the lining of the stomach. So it's something you can see very nicely. The epithelium of the stomach is really just covered with this secretory sheet of this mucus that covers the interior surface of the stomach. Within the stomach, things you can see on the microscopic include the gastric pits, which are these little shallow depressions that open onto the gastric surface. There's lots of mucus cells down in those pits that are actively making new cells and replacing the stomach wall. Because the stomach is kind of a hostile place with all of its acid, the lining of the stomach is continually being replaced, as it says there, actively dividing and replacing superficial cells. The gastric glands are mainly in the fundus and the body of the stomach, and they go down into the lamina propria. There are several kinds of cells. I don't believe you can tell the difference looking at these under the microscope. I can't tell the difference between which cells are parietal cells and which cells are chief cells, but you just need to know that those are two of the kinds of cells that make a lot of the fluid that's secreted into the stomach. So here's a nice picture of the microscopic diagram of the stomach. And once again, longitudinal layer on the outside, circular layer on the inside, and then inside of that is these oblique muscles that you see kind of scattered through there. Here's that muscularis mucosa, that little tiny layer of muscle that's up in right at the level of the mucosa almost. This is the lamina propria coming up in each one of those in between. Blood vessels, lymphatic vessels. I think we can end it at that. So these things here are what we call the gastric pits, these big places where it drops down in there. And indeed, we're going to learn here in a second that these glands and these special cells are down there in the bottom of it. This is a nice up-closer diagram that shows chief cells, and chief cells are only called chief cells because they're more common down in here. And then there's also these G cells or gastrin cells that live down in there as well. We'll talk about what they all make in a minute. I think that's all I need to say about that. The parietal cells, you should know, are the ones that make that intrinsic factor that I talked about that is going to help you absorb the vitamin B12 on downstream. The parietal cells also make hydrochloric acid. Please don't get confused by this because both the chief cells and the parietal cells make hydrochloric acid. Both of them do. But the parietal cells make the intrinsic factor. The chief cells make pepsinogen. Pepsinogen. Pepsin breaks down peptides, which are proteins. So pepsinogen is one of the enzymes that you need to be aware of, and it's just know that it's a enzyme that breaks down proteins, peptides. When it says pepsinogen, it's inactive. Once it's secreted out into the stomach, it meets up with all the other stuff that's out there, and it turns into pepsin. pepsin is actually the active enzyme. Okay, pepsinogen is the inactive proenzyme or pre-enzyme, sort of. Does that make sense? How does the body make hydrochloric acid? Well, it's complicated. It's not that complicated, but I just want to show you this, and I think you should study this on your own. I think this is not something I can present to you in a minute and a half. But this is a picture of the wall of the stomach right here. These are the parietal cells here in the wall. This is the interstitial fluid, so this is on the inside, and this is the lumen of the lumen of the stomach out here. This is where it's all the acid is. So sure enough, you can see here that we've got H and Cl being secreted out here. That's hydrochloric acid, HCl, is being secreted out here into the lumen, which is going to make it very acidy. And notice, because this has got a yellow dot right there, that is active transport. So these cells here are actively pumping the hydrochloric acid out. Now, if you pump hydrochloric acid out, you got to save something else, right, to keep everything in balance. And so you notice on the other side over here that there's this process called counter transport going on. And basically what we're doing here is we're pushing chloride into the cells from the interstitial fluid, and we are pumping out bicarb. HCO3 is bicarb, which is an alkali, right? So if you're pulling enough alkali out so that you have acid to secrete, that creates what is called an alkaline tide. Alkaline tide from the stomach. From the wall of the stomach on the outside, you've got this alkaline tide, which can actually make you alkalotic. If you secrete enough acid into your stomach, your body can become alkalotic from this alkaline tide here. I think I'll just kind of leave it at that. Tell you that the red lines are just interstitial diffusion. The blue lines are going the other way, obviously, and are basically counter transport is what's happening over here, as opposed to the active transport, which is going over there. So please read through that segment real quick. It's not tough. Just be sure you understand it. Pepsinogen is converted once it's exposed to the hydrochloric acid out in the stomach, it's turned into pepsin. And pepsin, as I said a few minutes ago, is the active proteolytic enzyme. Proteolytic means protein lysis, tearing down proteins into amino acids so that we can use them. We can absorb them. We can't absorb a chunk of hamburger across the wall of our intestines, but we can break it down to smaller things like amino acids and monosaccharides, disaccharides, and then absorb it. Pyloric glands are located right down there in the pylorus. They make a lot of this mucus. They also secrete gastrin, as I mentioned before. Gastrin is a hormone that's released by the wall of the stomach, and it causes the stomach to make more acid. Now, we always learned that gastrin was basically caused by the stomach being stretched open. Okay, so you stretch the stomach open when you eat a meal and it fills up a little bit. It causes the release of a lot of gastrin. The gastrin then makes the stomach make more acid, which then breaks down the food. Okay? Also, down here you have these D cells, which release somatostatin. And a somatostatin is just kind of the opposite of gastrin. So after a while, after you've been eating a while and your stomach's been filling up and you've been making lots of acid and more gastrin, which then causes more release of more acid, eventually you get to the point where you want to stop it and you start releasing more somatostatin, and that slows down the secretion of acid. And about that time, you're starting to push the food on out of your stomach. What is it that controls the secretion of gastric acid? Well, it's several things, and this is this is kind of important to understand that there's several phases of gastric activity and acidity. The first phase is called the cephalic phase. And I can tell you, and I bet this is true of all of you, if you've got a really good restaurant that you really like, when you walk in the front door and you think, oh man, I'm getting ready to have a great meal, and I'm looking forward to this, and your lips start smacking a little bit, and you've got extra saliva being made, and sure enough, your stomach is starting to make acid at that point, simply thinking about it. So it's coming from your brain, which is in your head, which is in your cephalad direction, from that end of you, right? Cephalic phase is you thinking about it. The gastric phase is the second phase, and that's when you've sat down at that table and you've taken a few bites and you're eating the potatoes that came with it and the broccoli and all that stuff, and sure enough, your stomach starts to expand. And the expansion of your stomach causes the release of gastrin, which I just mentioned, and that's caused by the gastric phase. The stomach expanding causes the further release, the second phase of gastric activity and release of acid. And then finally, you have the intestinal phase. Now, what do you think happens in the intestinal phase? Well, you're starting to push the food out of the stomach. Pyloric muscle is starting to open up. You're starting to let that food go on down into the intestine. And what do you think the intestine is going to say? It's going to say, whoa, stop. We got food coming down. You don't need any more acid up there anymore, right? You've got enough acid to digest the food, so stop. So indeed, the intestinal phase is when you start slowing things down. You with me so far? Okay. Here's a diagram to help explain this. I think I've touched on all of these little issues, but basically, the cephalic phase runs through the vagus nerve. You remember vagus nerve, number 10? And vagus nerve is the one that brings all of that parasympathetic stuff down. Almost 95% of all of our parasympathetic outflow comes through the vagus nerve. Goes to all the intestines. Well, sure enough, here's your vagus nerve. It's bringing it down from your brain. You're thinking about that food. It's signaling the mucus cells, the chief cells, the parietal cells, and the G cells to make more mucus, to make more pepsinogen, to make more acid. You are getting hungry. You are getting ready to eat, and your stomach is starting to secrete, getting ready for it. Okay? That's the cephalic phase. And really, the key is simply that it all comes down through the vagus nerve. Now, back in the day, in the first half of my surgical training, we used to do a lot of operations for ulcer disease. I mean, a lot. It was not unusual sometimes to go in the intensive care unit and there was 4 guys laying around in the ICU that were barfing blood from ulcers in their stomach. And we would give them Maalox and try to dilute all that acid. But then we would do surgery on them, and one of the operations, the most common operation we did was a vagotomy. We would cut the vagus nerve right up here at the esophagus, and you'd cut it so that you would eliminate this whole cephalic phase. Once you had your vagus nerve cut, you had no more stimulation of these mucus cells, chief cells, parietal cells, and G cells to make more acid, which was killing these guys because it was burning a hole in the wall of their stomach. At least we thought. We thought ulcers were caused by too much acid. Vagus. Step 2 is caused by the gastric phase, which is caused by the expansion of the stomach, the stretching of the wall of the stomach. And so sure enough, you've got these submucosal and myenteric nerve plexuses in the wall of the stomach, which causes these mucus cells, chief cells, parietal cells, and G cells to be stimulated further. It also causes the release of a lot of gastrin, and then the gastrin is a hormone. Gastrin is a hormone, and it comes back and causes the chief cells to make more, and it causes more motion of the stomach, more mixing, and so forth. So this is all caused by the stretching of the wall of the stomach, the gastric phase of gastric secretion. Final phase is called the intestinal phase, as I said. So now what happens is you've got food moving down here, and as it gets down here, the duodenum starts to stretch a little bit, and it starts sending inhibition signals. That's what these things mean, inhibition. It sends inhibition signals back here, and it says, chief cells, stop. Parietal cells, stop. Peristalsis, stop. Let's quit making acid. We have done our job. We have digested that food. Now we're pushing it on down. And as we push it on down, we secrete a couple more hormones, 3 more. One called CCK. You need to know about CCK. CCK stands for cholecystokinin. Cholecystokinin. What do you think that means?
Is that your gallbladder?
Gallbladder, exactly right. A cholecystectomy is removing a gallbladder. So when it says chole, you know it's relating to the biliary tree and to the gallbladder. So it releases cholecystokinin, which says, hey, stop everything. We're getting food on down into the duodenum. It's releasing GIP, which is gastrointestinal vasoactive peptide, and it's sending messages back here to inhibit all of these things. And suddenly, you've got a decreased pH here in your duodenum. You've got this acidy stuff that you had up here in your stomach, right? And now it's going down into your duodenum, and your duodenum is saying, oh, crap, it's so acid down here. What can we do to make it less acid? And so sure enough, your duodenum has these sensors that note the fact that it's decreased pH down here. It's becoming decreased pH means more acid, right? And that causes the release of secretin. Secretin, there's another hormone you need to understand a little bit about. Secretin says for something to secrete. Any ideas what you might be wanting to secrete all of a sudden? Buffers, that's a good point. Now, if you've got acid pouring in and you want to make a bunch of buffers, well, what makes buffers? What makes an alkaline solution that we can dump into our duodenum that will neutralize that acid? Well, it's sodium bicarb, that's a lot of it. But what organ makes this stuff?
Pancreas.
The pancreas, that's right. The pancreas, remember, it lives right in here, and it gets, when the acid comes down here, it signals to the pancreas, hey, we need some more of that pancreatic juice. Pancreatic juice is very alkaline. Very alkaline. It also has a bunch of digestive enzymes in it, but it's very alkaline, and so you've got acid coming from here, you've got alkaline coming from the pancreas dumping in at the duodenal papillae right along in here, which is where the pancreatic duct enters into the duodenum. You've got all of that decreased fluid coming in there that neutralizes the acid, so that by the time the fluid gets to about right here where the CREAS is, it's neutralized. It's gone from a pH of 1 to a pH of 7. It's neutral. Okay? Secretin is the hormone that is released by the wall of the duodenum in response to acid that tells the pancreas to make a bunch of pancreatic juice, which is alkaline, dump it in, to mix with it to neutralize everything up cool. Okay? I think I've said everything that's on that slide, but I'm not willing to read it either.
Okay.
I should take that slide out. So, I've said that really there isn't a whole lot of absorption at all in the stomach. The stomach performs this preliminary digestion. You've got some pepsin mixing with it that's starting to break down some of these proteins. You've got some digestion of carbohydrates caused by the salivary amylases, the carbohydrate enzymes that are from the mouth. And you've also got some lipids being broken down. here in the stomach by this lipase, which was secreted by your by the lingual salivary glands. Question?
What about oral medications? If they're not, you said something doesn't absorb anything. Again, not that Anadol will be working in the stomach.
Most drugs are not absorbed in the stomach. They're also passed on through into the intestine where they get absorbed. Yeah. Now, there's a few exceptions. Obviously, nitroglycerin, you put it under your tongue, it's absorbed right through the mucosa of your... But I can't think of much of anything that's absorbed through the wall of the stomach itself. Yeah.
I'm a little confused about B12 because, like, at home I have sublingual B12 vitamins,
Really?
and I wonder if they're digested in the stomach. How does that?
Well, if there's sublingual.
No, they just...
No, I mean lower. Then how does it re-enter?
I don't know.
Okay.
I don't know the answer to that.
Are you thinking about it?
I'm thinking about it. I'll try to look it up. I don't think it's absorbed through the wall of the lip, though. I mean, of the mouth. It could be. They tell you to take them and put them under your tongue. That's cool. So if you think about what I just said that some of the proteins are broken down by pepsin in the stomach, some of the carbohydrates are broken down by the amylase in the stomach, and some of the lipids are broken down by the lingual lipase. And that's all we got. That's all we get to eat. You know, we get to eat carbs, we get to eat fats, and we get to eat proteins. That's it. Check your little nutritional thing on the back of all your food, and it lists how much is what each of those three. That's the only three forms of food we actually digest and absorb. So they're all being broken down in the stomach. And that's kind of cool. So the stomach contents have gotten very, very acid. That makes the pepsin really active. Protein disassembly, that's an interesting word, protein disassembly. Protein breakdown begins. And so although this digestion is occurring in the stomach, and when we say digestion, remember we mean mechanical digestion, which is chewing it up and breaking it down, mixing it up, getting it wet, and also chemical digestion, which is actually breaking down the molecules into smaller parts. Okay? But they're not really absorbed here. Now, it's time for the small intestine. The small intestine has three parts. The first part of the small intestine is called the duodenum. The second part of the small intestine is called the jejunum, and the third portion is called the ileum. Okay? All three of them are involved in absorption. Okay? We'll talk about it. So about 90% of all of our nutrient absorption occurs in the small intestine. Where does the last 10% occur? In the colon. The colon doesn't absorb much at all except water, just so you know. We'll talk about that when we get to it. All right, so the duodenum is the segment of intestine closest to the stomach. It's only about that long, 10 inches or so. It's basically a mixing bowl that receives all of that chyme. We call it chyme now, this juice that's coming out of the stomach, and all of these digestive secretions from the pancreas and the liver. We haven't really talked about the liver, but the liver dumps in right there in the duodenum as well. That's basically all it does in the duodenum. It's pretty tough because it's receiving these acids and it's neutralizing them right there before it can really corrode the walls of the duodenum. The jejunum is the middle segment. It's about 8 feet long. 2.5 meters, so it's pretty long, and most of the absorption really goes on in the jejunum. It's the most important part. The jejunum has few pliky circularies. Remember what they are? Those are little folds that go circular in the walls, and it has pretty small villi. But obviously it has a lot of surface area, a lot of heaps and lots of villi, giving it lots of surface area in which to absorb all this stuff. Yeah?
So if something happens to somebody's jejunum, how much
How much can they lose
Yeah.
and still be able to absorb their food? Really good question. I had a guy who came in to Bethesda one time, and he was just screaming in pain. I'm glad I wasn't on when he came in, because the guy that was taking care of him thought, "Shut up, damn it, quit yelling, and let us take care of you." And he was just screaming and screaming and screaming. He was a retired Marine colonel, really good guy. And what had happened was his bowel had twisted inside of his abdomen, and it was hurting him because it wasn't getting any blood. And we ended up getting him to the operating room about 4 hours later. And after trying to figure out what was going on, we couldn't figure out really, so we finally said, well, let's just operate on it and figure it out. Well, we got in there, I wasn't there even, and his bowel was all black. It was dead. It had been twisted, and so the arteries that come up through the mesentery had gotten twisted off. And he lost almost his entire small bowel. He lost his entire jejunum, his entire ileum, his entire right colon. The right colon got twisted, and he lost all but about 3 inches of his duodenum. That's all of the small intestine he had. And that leads to a condition that's really tough. It's called short bowel syndrome, as you might imagine. He has a very short bowel, and therefore he can't absorb much. Jack Newman was his name, and Jack ended up spending the next 1.5 years in the hospital with us. We all got to know him really well. He was like part of our family. We basically fed him through a hyperalimentation line in his subclavian vein, just giving him protein and carbohydrates through a hyperal line. And then gradually starting to introduce him to some foods, but you couldn't really give him food. You could just give him very special diet with a few proteins, a little bit of carbohydrate in it. And gradually, after about 1.5 years, we got him to where he could live and maintain his weight just on stuff that he took by mouth. Now, most of it actually went in through a feeding tube because it was yucky and it was just basic chemicals that he was getting. But he lived and lived a long life after that. So the point being is that you can lose almost all of your small bowel. Now, who loses their small bowel? Not many people. Most people, even if they twist their bowel, they don't twist as much as Jack did. But we had patients that had Crohn's disease that would involve, 80 or 90% of their bowel, and they would end up getting it resected because they couldn't live with it, and they couldn't live without it either. But they would lose tremendous amounts of weight and have short bowel syndrome as well. So be thankful you've got your guts. Let me tell you, it's a lousy life when all you can eat is amino acids and a few basic sugars without it running right out your butt. Yeah.
And that's what I was just gonna say. My brother actually does not have a large intestine
Yeah.
because of ulcerative colitis. They removed it, thought he had ulcerative colitis, and then about 8 years later, they were like, "Oops, you have Crohn's instead." So.
But they didn't do
it's-
anything wrong.
Yeah.
Yeah.
It's hard to
Yeah.
detect, but it's constant diarrhea for the rest of your life.
Yeah.
And a lot of supplements.
Right. Yeah, it's tough. It's a tough deal.
How do I prevent my bowel twisting? This is also hard.
Basically, most all bowel torsions and things like that happen in people that have had other kinds of surgery, that have had their mesenteries freed up so that instead of being stretched out and wide where they can't twist, they get narrow, and it's also caused by adhesions, scar forming in your tummy that gives you something to twist around.
Some of them resolve on their own too.
Yeah, some bowel obstructions absolve on their own. Some volvulus means twisting. That guy had the worst case we ever heard of or saw, or before or after. It was just a tragedy. Anyway, the ileum is the final segment. It's about 11 feet long, so it's actually the longest. At the end of it, it has what's called the ileocecal valve. The ileo, from the ileum into the cecum, which is the first part of the large intestine. There's a little muscle valve there. that controls the entrance of the juice from the small intestine into the colon. I've got pictures here in a minute. So here we go. This is a nice little diagrammatic picture. When you look at the bowel from the outside, the three parts look exactly the same. You don't know, I mean, the blue segment of the duodenum is not really blue, and the purple segment is not really purple. You just have to assume that there's about 8 feet of jejunum, and then it becomes ileum, and then the ileum weaves around and gets right here to where the ileum enters the cecum. That's where the ileocecal valve is that kind of slows it all down. Then it goes into the colon, or the large intestine. It goes up the ascending colon or the right colon, goes across the transverse colon, which has been cut out in this diagram here. That's the transverse colon, comes up here and comes down the left colon or the descending colon. It makes kind of an S-shaped turn down in through here. That's called the sigmoid colon. S, sigmoid, get it? That's Greek for S. And then it goes out through the rectum to the anus and then out of the body. This is that jejunum. What the jejunum looks like has a bunch of plicae circulares, these folds that increase the amount of surface area, so there's more room to absorb the food we need to absorb through the wall of the small intestine. I think when you look at these under the microscope, you won't have any trouble identifying the villi. It's just a constant villi on the inside of the small intestine. There are some intestinal glands, lots of mucus cells, or goblet cells, call them what you like. It's columnar epithelial cells. The intestinal glands are making lots of mucus into the bowel. We'll talk about fluid balance here later. But believe me that the small intestine pours tons of fluid in to mix with the chyme, that's what we call the stuff inside the bowel, as it flows through there. There's also a series of enzymes that live along what's called the brush border of the small intestine, which are enzymes that really help you absorb the food. So if this is a plicae circularis, one of those folds like you see here, and then there's zillions of villi there, that's creating a massive amount of surface area where we can do our absorbing that we need to do. This looks like an old slide that we've already talked about. I don't expect you to study these nerves, these little nerves called the myenteric plexus. It's just what it says. It's the muscle plexus of nerves that helps coordinate the contractions of the small intestine. Enough said about that. That's about all you need to know. There's another little submucosal plexus up here. Once again, not very important. Mostly the bowel kind of runs itself and contracts itself. This is something you ought to be aware of, and that is the fact that in these villi, which are covered with, columnar epithelial cells and a lot of goblet cells in between, mucus cells, which you see labeled here, there are these things called lacteals. Now, lacteals are lymph vessels, lymphatic vessels. See, lymphatic vessels, they color them green for no real reason. They're certainly not green in real life, but that's what they look like. And notice that there is a lacteal going up into each one of those little things. And notice that the lymphatic vessels have little valves in it that open and allow the fluid to go one direction, but it can't come back. Remember, the lymphatic vessels are going to work their way up to the thoracic duct and end up going back up into the thoracic duct, empties into the junction of the brachial and brachial and the jugular vein up here in the neck, subclavian, I guess, and jugular vein, and it goes back into the bloodstream. Yes.
Now, if you found lymph vessels just loosely in your intestine, would that be a sign of cancer? Could that be?
If you have a cancer, oftentimes the cancerous cells will break off and go and travel through the lymph vessels. They usually then get caught at lymph nodes, and then the lymph node itself becomes full of cancer. Then it's kind of a lump there. You can see those. The reason I wanted to talk about these is the reason they're called lacteals. When you think lact, what do you think of? Lactate, lactation, milk, okay? Lactic, it means milk. It's the sugars found in milk, or lactose. Okay, well, most of the time when we would operate on people, they had not eaten, usually since the night before. We would take everybody that was going to have surgery in the morning and say, okay, you can't have anything to eat after midnight, and so they wouldn't have any food in their intestine. But occasionally, you would get somebody in who had just stopped at McDonald's and had a hamburger and ordered fries, and then they'd gone down the road and run their car into somebody else, and they got hurt badly. They'd bring them up to the operating room, up to the hospital. We'd decide they need an operation for some reason or another. And when you operated on them, you would look at their bowel, and their bowel, all of these little lymphatic vessels were full of fat, and it was white. And that's where they got their name, lacteals. Because when we operate on people that have just eaten and they're absorbing fat out of their bowel, and that's the way we do it. We absorb fat droplets directly through the wall, directly into the lymphatic, into these lacteals, and then they go this way. And we got the fat, which is a good thing to have if you're trying to stay alive, if you need the calories especially. So we can see them. We didn't see them all that often because we didn't usually operate on people right after they ate. But once in a while you would. And that's where they got their name. We'll talk about that more. So here's a lacteal illustrated right here in the lamina propria, the submucosa areas down in here. Notice there's lots of mucus cells around the outside. The cells that aren't mucus cells are simple columnar, right? These brush border enzymes are actually very much a part of the surface of these absorptive cells. So they're not floating free kind of enzymes. They're kind of attached to the wall. They're integral with the membrane itself. Okay? And they're on the surface of these intestinal microvilli, and they actually help break down the materials that come in contact with the surface of the intestinal cells. And because of these enzymes, we can absorb them straight into the intestinal cells. Once they get into the intestinal cells, they're kind of within our body. Remember I talked earlier about how things, when they're still in our intestine, they're really not part of us yet. But once we get them absorbed across the mucosa and into these cells, they really are part of us. And you remember, you are what you eat. So there's several enzymes. Please don't try to memorize all of these. I'm going to tell you the few that you need to. I mentioned them already really much. But there's enzymes that come from the pancreas. Trypsinogen is another one. What do you think trypsinogen breaks down? Trypsin. Then there are these enteroendocrine cells. Entero means gut. Endocrine means hormones. So they're hormones that are released by the gut. Now we've talked about 3 of them already, and here's the 3 that are probably the most important. One is gastrin. Where did gastrin come from? The wall of the stomach. When the stomach stretches, it releases gastrin, which causes the stomach then to make more acid. Cholecystokinin. When food dumps into the duodenal wall secretes cholecystokinin. What do you think cholecystokinin does? It makes the gallbladder contract. Gallbladder is just kind of a blind pouch there. And when you get a bunch of food in your duodenum, your gallbladder contracts, pushes bile on into your intestine. It also neutralizes acid.
So what happens if you have a cholecystectomy?
Wait, let me answer that when we get to gallbladder in about another 8 or 10 slides.
Okay.
Thank you. And the last one, The last one of these enteroenzymes is secretin, which I already said is secreted by the wall of the duodenum in response to the acid from the stomach coming out. And the secretin says, wow, it's too acid in here. We need a bunch of pancreatic juice, and so it secretes secretin. Secretin then goes and stimulates the pancreas and says, pancreas, make more juice and push it on in, and that's what happens. It secretes, and pancreas is alkaline to mix. Okay, the wall of the duodenum is very interesting under the microscope. And remember, the duodenum is where you've got strong acid coming in and mixing with strong alkali from the pancreas. So because of that, the duodenum has to be very, very well protected, and to do that, it has an extra copious amount of mucus made there. And it's made in these glands called the submucosal glands of Brunner. Well, I hate eponyms. We can just call them the submucosal glands of the duodenum. But basically, they are there to make extra special, extra lots mucus to protect it from that chyme arriving from the stomach, the really acidy stuff. I'll show you pictures in a sec. But they're classic. I mean, once you see these glands that are deep in the submucosa, you won't forget them. They don't appear anywhere else except in the duodenum. Okay. Intestinal secretions. The intestines make lots of juice. 1.8 liters per day. That's basically 2 quarts a day. About this much. That's 2 liters. No, it's not. 975. That's a liter. So this is about a liter. So 2 of these is how much fluid the small intestine makes and pours into your bowel every day. I'll just leave it at that. The movements, the peristalsis keeps working to kind of push the food and the chyme, it's called, to push it on downstream. But it also kind of segments it. It does this thing called peristalsis and segmentation. And if I was going to describe segmentation, it would be like this. Peristalsis is like a loop of bowel goes pushes things on down. That's peristalsis. Segmentation is when it does like this. It doesn't make those noises, but that's what it does. And so it basically is sloshing the fluid back and forth through the small intestine. It's not really under CNS control. And what it's doing is it's keeping the wall of the small intestine, the mucosa that's going to be absorbing all this stuff, it's keeping it exposed to a new set of fluid all the time, right? Because if you let it just sit there, it would absorb all the stuff that's easy, and then you would have absorbed it all, right? You need a constant changing of that so that there's always stuff there for the mucosal wall to absorb. I can't talk without my hands. Have you guys figured that out ever? Okay. We have several reflexes that go on here, and I bet each one of you has experienced these at some time in your life. One is the gastroenteric reflex, the stomach to small intestine reflex. In other words, when your stomach fills up, you send reflexes to your small intestine, and they say sort of, hey, small intestine, we got some more food coming down. You better get to moving and get the small intestine cleared out because I got more coming. That's the gastroenteric reflex. We have another one called the gastroileal reflex, which relaxes the ileocecal valve, remember, which is at the very end of the small intestine, right where it goes into the colon. And it basically says, hey, we got a bunch of food up here in the stomach, in the gastro and ileum, you better empty it out down there because we got more coming. Now, you guys have all experienced that, whether you like to think about it or not, but I'll bet every one of you has been sitting there at the Thanksgiving table once or twice in your life, and you're eating a bunch of food, and all of a sudden you realize, whoa, I gotta go to the toilet. Because you've sent a signal down there to your large intestine at the ileum to receive all this extra stuff that's in your small intestine to make room for this big meal that you just ate. And sure enough, your colon gets it, your rectum gets it, and you got to go to the bathroom and empty it on out. And that's really your gastroileal reflex working. So the parts of our bowel kind of talk to each other. Makes sense, doesn't it? Let's talk about the pancreas for a minute, because we really haven't. We've kind of skipped over it. It kind of lies posterior to the stomach. It kind of goes from the loop of the duodenum there, where the duodenum is making that twist. Pancreas kind of stretches out and goes out to the spleen. I'll show you a picture in a minute. Our pancreas is very much bound into our posterior abdomen. It's not out in with the guts like it is in the cats and like it is in the rats that we do in lab. In humans, it's very much retroperitoneal, behind the peritoneal cavity. It's in the back. It's not, there's not much to it. I mean, you kind of look at it and you could suck it away with a sucker. It's not very tough stuff in humans. It's got a thin connective tissue capsule, like it says there. It's divided into parts, which is silly, but there's a head, there's a neck, there's a body, and there's a tail. They left the neck out here, but a lot of people include the neck. But basically, that's just the length of the pancreas. The head is the most important part because that's where it dumps into the duodenum. And I'll show you pictures here in a second. 99% of the pancreas is little bitty lobules, which we call pancreatic acini. Now you can think of pancreatic acini like a cul-de-sac. It's a little cul-de-sac, a bunch of houses around the edge of it. They all make juice. They put the juice out into the cul-de-sac. Cul-de-sac goes down, meets up with a few more streets, and it goes together and forms bigger and bigger ducts. And then eventually forms one big pancreatic duct that goes the length of the pancreas and dumps it into the duodenum. So this concept here of these pancreatic acini, these little cul-de-sacs, is what you see on 99% of the pancreas when you're looking at it under the microscope. They're blind pockets. They're lined with simple cuboidal epithelium. They are exocrine glands, right? Exocrine. Dump into ducts, and yet scattered about through the pancreas are these little islets, which we call pancreatic islets. They make up less than 1% of all of the pancreas, and you've probably heard them referred to as the islets of Langerhans. That's the Jeopardy question you'll see about every 2 weeks on Jeopardy. We're going on a trip to the islets of Langerhans. Where is that? The answer is, what is the duodenum, right? You got to answer it as a question. But anyway, so the pancreatic islets, and they look very different than the rest of the pancreatic tissue. So here's kind of schematically what it looks like. Here's the head of the pancreas, here's the body of the pancreas, here's the tail of the pancreas. Here's the opening at the duodenal papillae, also called the sphincter of Oddi. That's a name you'll hear because it's been around so long. But that's where the juice from the pancreas empties into the duodenum right here. Remember, the juice from the pancreas is quite alkaline. It's mixing with acid that comes here from the stomach. Remember the pylorus is right about here, where it dumps into the first part of the duodenum right there. Looking at the pancreas, it kind of looks like this. Here's these little cul-de-sacs, these little acini that you see here. They're all emptying into gradually enlarging pancreatic ducts. A lot of them, if you don't cut them just right, you won't see the place where they open like you do in that one. But most of them look like this. And indeed, that's about 99% of the pancreas. But then when you look at slides of the pancreas, you'll notice every so often one of these islands. They look very different. Here's a picture of one. This is a pancreatic islet there. All the rest of the slide that you see here is nothing but these little pancreatic acini. Is the exocrine portion of the pancreas. The exocrine portion, which is making pancreatic juice and digestive enzymes. 99% of the pancreas. What are the functions of the pancreas? The pancreas, mainly it's these endocrine cells, which are in those little islets. They secrete insulin and they secrete glucagon. Now, they actually secrete a couple other little things, but that's the only two I want you to know. I want you to know that they secrete insulin. What's insulin? What's insulin? It's what?
It's the molecules that bind the sugars.
They bind the sugars. Who takes insulin? Diabetics. Diabetics can't make enough insulin themselves, so they end up taking insulin, which keeps their blood sugar from going too high. So insulin lowers your blood sugar. Okay? The opposite, glucagon, which is the other hormone made in the pancreatic islets, raises your blood sugar. So the balance between those two of insulin to lower your blood sugar and glucagon to raise your blood sugar is what controls our blood sugar and keeps our blood sugar levels normal. Okay? When you get to be a diabetic and you don't have enough insulin, then things get out of whack. Your blood sugar usually goes high and you end up taking insulin. Bring it down.
So, insulin and glucagon are synergistic to each other. They work together.
No, they're antagonistic.
They're antagonists, sorry.
Right. So remember, that's just 1% of the pancreas, but it's a very important 1%. The exocrine cells, which is the rest, they secrete this pancreatic juice, which is not only alkaline, but it's got lots of enzymes in it to help break down your food. We make about 1 liter of pancreatic juice a day. Here's 1 liter. That's a lot of pancreatic juice. Now remember, the stuff about this pancreatic juice is it's full of these enzymes, these pancreatic enzymes here, that are designed to help you break down stuff. So if you took that quart of pancreatic juice and you had a tear in your pancreatic duct, and instead of dumping this into that little tube that goes directly into the duodenum, but you just dumped it into your back around the pancreas, think what it would do. It would eat up everything inside of you. That's kind of what pancreatitis is. When the juices from your pancreas get loose, it's sort of like, we always describe it as taking a bucket of hot oil and dumping it in your back, because it literally just, because of these pancreatic enzymes, it starts eating you from the inside. Not a good thing.
So I'm assuming it's painful.
Yeah, it's very painful. It's usually pain in the back, by the way. All right, so here's a number of these pancreatic enzymes. I don't think you need to know much about them. I think you should know that anything that has the word amylase in it breaks down carbohydrates. Remember, it started in our mouth with amylase and the saltine cracker. Okay. A pancreatic lipase, what do you think it breaks down? Lipids, fats. It releases and turns it into fatty acids, which then we can absorb right into our lacteals, basically. Nucleases, pancreas secretes nucleases. Guess what they do? They break down nucleic acids. So DNA and RNA in that piece of beefsteak you just ate, it's got to be broken down too. And so that's what these do. And then it's got lots of proteolytic enzymes. Proteo, protein, lytic, cut it up, tear it apart. Proteolytic enzymes breaking the proteins apart. You can call them proteases if you want. Proteases break down proteins. You can call them peptidases. Peptidases breaking smaller pieces of protein down into their individual amino acids, right? The liver. I'm going to go on and go through the liver here because it's just so important and it's so cool. I just love talking about the liver, so I'm going to talk. We get to the lab a few minutes late, you get to the lab a few minutes late. The liver is the biggest organ in our tummy. It weighs, a bunch. It says there 3.5 pounds. Where does it live? It lives in the right hypochondriac. Hypochondriac, underneath those cartilages, right? Remember that? And in the epigastric region, which is the center above the stomach right here. Extends over into the left hypochondriac a little bit over there, extends down into the umbilical region. The liver can get very, very big. I've seen patients that have a liver that goes all the way down into the bottom of their pelvis if the liver gets really big.
How does it get that big?
What? Fatty liver. Hepatitis can make it get really big. Obstruction of the bile ducts, things like that. I think the thing to think about the liver is the liver is the main metabolic factory of your body. It breaks down everything. It also builds everything that you need. So it breaks down stuff and it builds stuff up. And we'll talk about that very briefly. It's got a tough layer around the outside of it. You guys have seen that in the lab already. The outer layer of the liver is a little bit tougher. It's the visceral peritoneum is about all it is. The liver is divided into lobes. The rats and the cats do not make good representatives for the human liver. The human liver really only has 2.5 lobes, kind of. I helped some kids do a rat dissection the other day. I think their cat had 7 lobes to their liver. So we have a lot less. If you looked at the liver in cross section, this is a CAT scan view. Here's the liver right here, and you notice that this thing here called the lesser omentum. Remember, the lesser omentum comes off of the lesser curve of the stomach. And the lesser omentum used to come off the front of the abdomen. It was the ventral mesentery. Remember that? And you see there's still a little bit of this thing up here left called the falciform ligament that kind of holds the liver up there. But it's just an old remnant. Now here's the lesser omentum right across here. Here's the blood vessels. Here's the stomach. This is the lesser curve of the stomach. This is the greater curve of the stomach. Notice that out here is the spleen coming off of that as well. Here in the back is the vena cava, the inferior vena cava, and the aorta. Aorta carrying blood down to the legs, vena cava bringing all the blood back. Okay? Notice that right above the liver is this little layer of muscle right here called the diaphragm. And below the diaphragm is the peritoneal cavity. This little black ridge right here is in the belly. Right? That's the peritoneal cavity. And right above the diaphragm is this little cavity, which is the pleura. Right? That's the cavity that holds the lung. They're very, very close. Here's the liver looked at from the front. There's a big right lobe. There's a medium-sized left lobe. There's a quadrate lobe that's back here in back that we'll see in a minute. Here's the gallbladder in the human. You can see the gallbladder very easily. Here's the round ligament and the falciform ligament, which is that ligament that attaches up to the front. And you remember from the umbilical cord of the baby, when the blood came back from the placenta, it comes back through this round ligament and goes straight through the liver. And that little bypass that it takes going through the liver is called the ductus venosus. Remember that? The ductus venosus. And then when the doctor cuts or clamps the umbilical cord, it stops any blood from flowing through there, and so it clots, and it turns into a little piece of scar called the round ligament. Okay. Here's looking at the underside of the liver. this is kind of the center lobe or quadrate lobe, caudate lobe. It's pronounced and spelled a number of different ways. Okay. Two things that are very important for you to understand. One is the blood supply to the liver, because the liver has a very weird blood supply. Blood comes into the liver from two routes. Blood comes into the liver from two routes. The first is it comes in through the hepatic artery. The hepatic artery is a branch of the celiac trunk. Remember that? The first of the unpaired arteries. So the hepatic artery carries bright red blood straight from the aorta to the liver. However, the liver has a secondary source of blood being delivered to it, and that is called the hepatic portal vein. You must name it properly. You must call it the hepatic portal vein. Don't call it the hepatic vein, because that's a different animal altogether. You got to call it the hepatic portal vein. The portal vein is taking the blood from all of your guts and taking it straight to the liver. It's a portal system. Remember, portal system is a system of veins in your body that goes from one set of capillaries to another set of capillaries without going through the heart in between. We had one in the hypophysis, the hypophyseal portal system, remember, that carried blood from the adenohypophysis, or from the from the hypothalamus, carried it down to the hypophysis so that those releasing hormones wouldn't get lost in the big circulation. Okay, so here's the hepatic portal vein, and it's also coming in along with the hepatic artery. That's the two sources of blood going to the liver. And I'm going to become more clear about those in a minute. So we got two sets of blood coming into the liver. One is bright red arterial blood from the hepatic artery. The second is dark blue blood, but it's extremely rich in nutrients because it just came from the bowel, where we were absorbing all that stuff out of our intestine, and it sends it straight to the liver to get processed. And that's where we're going to process all those carbohydrates, proteins, and fats. Now, how does the blood leave the liver? Well, the blood leaves the liver through the hepatic veins. The hepatic veins. And remember, we called the first ones the hepatic portal veins. They're going to the liver. Now the hepatic veins. The hepatic veins leave the liver. There's a right and a left one, basically from the right lobe and the left lobe. And where do they go? They go straight to the vena cava. And from the vena cava, they go straight back to the heart. So this is the blood after it has completely percolated through the liver. Now the interesting thing about this diagram right here, and this is why of all the things that I didn't want to see come into the emergency room, it was a patient that had a seatbelt on that had gotten thrown really hard against the seatbelt or against the dashboard, and they were bleeding into their abdomen, and they had torn these veins. The veins, they're kind of coming in from all around. They're not shown on that diagram, but they kind of come in from the liver into the vena cava from a bunch of different directions. The problem is they're buried within the liver. You can't get to them, and they bleed like hell. And so you can't see, and if you go in there and try to sew, it's bleeding at you so fast you can't really do much. So most of the time, we would just end up kind of packing them with a bunch of sponges and hoping it would stop. Torn hepatic veins are very, very lethal. It's a very lethal traumatic injury. Okay, so let's talk about the hepatic blood supply. I'll break it down a little bit further. About a third of the blood comes from arterial blood. This is the bright red stuff that comes off the hepatic artery proper. That's about a third of the blood that flows to the liver. And about 2/3 of the blood is actually venous blood, so it's already blue or purple, and it's coming from the hepatic portal vein. Where does it come from? It comes from all of the intestines, basically the esophagus, stomach, small intestine, and most of the large intestine. So that blood, after it gets sent out through those things like this superior mesenteric artery, remember that, carries blood to the small intestine. Well, then it comes back to the veins, but it doesn't go back to the vena cava. It goes to the portal vein, and then it all comes up and goes to the liver. Because remember, it's just been through the intestines, and it's picked up all these nutrients. So about 2/3 of the blood going into the liver is coming in through the hepatic portal vein. And when it gets to the liver, it goes into these little things called liver lobules. And all of the liver is nothing but a big collection of 100,000 or so liver lobules. They're about 1 millimeter in diameter. And I can promise you that if you get down and look at the liver really closely, even with your naked eye, you can kind of see these little tiny, tiny speckles that are the lobes, lobules of the liver. About 1 millimeter in diameter each, it says there. They are hexagonal in cross-section. Hexagonal means how many sided? 6-sided, right? And so they're 6-sided, and at each one of those corners, there is what's called a portal triad. So each one of these corners right here, there is what's called a portal triad. Or hepatic triad. Or portal triad, either one. All right. These triads have 3 things in them, and you need to know these. It has a branch of the hepatic portal vein. So, there's a portal vein. It's coming from the guts. It's got lots of nutrients in it. It's dark purple. It's already lost its oxygen. It's got a branch of the hepatic artery. So it's got a little bitty artery that's coming there. Coming from the hepatic artery, it's still bright red. And it's got a small branch of the bile duct. What does that mean?
Dot markers.
I've got markers and I'm using them too, baby. What's a bile duct?
It's gonna carry the bile.
It carries the bile, that's right. And bile is made by the liver. So bile is kind of the product of the liver. It makes bile. Bile is going to eventually be dumped into the intestine from the common bile duct. Goes into the intestine at the duodenum. So you've got 2 blood vessels carrying blood into the portal triad, into the liver lobules, and you've got one coming out. The one coming out is the bile duct. Okay, the bile ducts are going to branch together, meet up, until they get bigger and bigger, and then we'll find, eventually we will find the bile ducts and the gallbladder hanging off the end. So here's kind of a picture of it. So this right here is a portal triad or a hepatic triad. Notice there's the big blue hepatic portal vein. Notice there is a hepatic artery, bright red, and a little tiny bile duct. Now, they dump all this blood into here, and then that blood comes out here and percolates amongst all of these cells. All these little boxes here are hepatic cells, liver cells. And the liver cell gets the blood on one side and kind of processes as it flows, as it works its way through the liver cells. And on the other side, it puts the bile out into the bile duct. And the rest of the blood continues to flow on through. The rest of the blood flows on through, and it collects. Where does it go? Notice there's artery blood and venous blood. It's coming out here, and it collects in this big vein, which is out in the middle of these lobules. So out here in the middle is the hepatic vein. Remember, this is the hepatic portal vein. This is the hepatic artery. This is the bile duct. Okay? The blood all pours into the liver. It gets processed through the liver. When the blood's ready to leave the liver cells, it collects here in the middle in the hepatic vein. And this is the hepatic vein that then meets up and goes into the vena cava from all sides to go back to the heart. Okay? So here we go. Here's the triad right here. Bile duct, hepatic portal vein, hepatic artery. They dump the blood out, and these both come in this direction. The blood flows through the hepatocytes, these hepatic cells, these liver cells. It connects and comes to the central vein. Central vein is the one in the middle right here. And then the central veins come together and carry it to the hepatic veins. The veins get bigger and bigger until there's like 6 or 8 of them that empty into the vena cava within the substance of the liver itself. Illustrated over here. Okay? Nice picture, close-up picture. Bile duct has always got cuboidal, I believe it's cuboidal, and some muscle around it. Here's a branch of the hepatic artery. Here's a branch of the portal vein. Remember, veins are always bigger and thin-walled. A lot of hepatocytes. These are just liver cells working its way through the liver. Hepatocytes are liver cells. They adjust the level of nutrients. They take stuff out. They put stuff back in. And I think it also includes some Kupffer cells. You should know this word. These are reticuloendothelial cells. What are reticuloendothelial cells? They're kind of like macrophages and cleaner upper cells, right? That's right. The other thing that the liver does as the blood is flowing through the liver is picking out what it wants, and it's also manufacturing a lot of things that our body needs. For example, plasma proteins, albumins, globulins, blood clotting factors, all kinds of things that our body needs to make are made in the liver as it goes through. The other part leaving is the bile. The liver secretes this bile. It connects up through these little bile canaliculi. They eventually form together, and become the common hepatic duct. Now let me just make another diagram quickly. And hopefully if you get this, you'll want to remember this forever. People will always be asking you. That was a joke. Here's a right hepatic duct, and here's a left hepatic duct. We're looking from the front. So here's the right hepatic duct, and here's the left hepatic duct. They come together, and guess what they form? The common hepatic duct. Okay? The common hepatic duct. The common hepatic duct comes down this way, and it gives off this little side branch, which is called the cystic duct. And the cystic duct connects to this thing here called the gallbladder. Okay? So this is the cystic duct. From the point where the common hepatic duct and the cystic duct come together, this tube right here is now called the common bile duct. Common bile duct comes down here, kind of passes behind the duodenum. Here it goes behind, and it comes through this thing here, which is called the pancreas. The pancreatic duct comes in here. The pancreatic duct meets up with the common bile duct just before this goes right in here into the wall of the duodenum, which is where the bile dumps into the duodenum. Okay? So, right hepatic duct, left hepatic duct come together to form the common hepatic duct. The common hepatic duct gives off the cystic duct, which goes to the gallbladder. The gallbladder is nothing more than a reservoir, and it fills up between meals, and then it squeezes down, empties out, pushing the bile on down here into the duodenum, down at the bottom, and meeting up with the pancreatic duct, remember, which is going to contain all of that alkaline stuff. Common bile duct is formed by the union of the cystic duct and the common hepatic duct. Passes through the lesser omentum towards the stomach, penetrates through the wall of the duodenum, meets up with the pancreatic duct right at the ampulla, right there. This is kind of a cute picture showing this. Here's the cystic duct coming through here. The cystic duct has a bunch of spiral valves in it, they call it, and it comes down, meets up. Common hepatic duct goes around in back of the duodenum, as illustrated here, meets up with the pancreatic duct right here as it dumps into the duodenum. Remember, here's the portal vein coming into the liver, hepatic portal vein, and common hepatic artery carrying the arterial blood up to the liver as well. I'm going to stop right here at the gallbladder. We'll talk about gallbladder disease first thing tomorrow. Okay? Sorry I ran over a few minutes, but God, wasn't that fun?
It was scintillating.
Wasn't that great? Thank you so much.
I'm gonna sleep so good tonight.
It works. Okay, so we were talking the other day, we finished up liver pretty much. Maybe we have a little more liver. We finished up the pancreas. We're down in the duodenum. We're working our way on down the tract. The duodenum is where the pancreatic duct and the common bile duct come together just as they go out through the duodenal papillae and empty out into the duodenum. So this is the duodenum over here. And remember that the duodenum is just outside of the stomach, so there's this really harsh acid stuff being poured down into the duodenum. But luckily, the duodenum secretes this hormone called secretin, which tells the pancreas to make a bunch of alkaline solutions, which it does, and they get pumped in here through the pancreatic duct in order to neutralize the acid in the duodenum, so that by the time you get just past this, usually things are pretty well neutralized for the rest of the trip through the GI tract. This duct is kind of complex right in here. People do develop tumors of the duodenal papillae right here. People pass gallstones down through their bile duct here that get caught right here. And when they get caught, they also block off the pancreatic duct, which then can cause really bad pancreatitis, which I talked about a little bit the other day. That's where the juices from in the pancreas kind of get released, and the pancreas sort of starts to auto-digest itself, and people get really, really sick from that. But anyway, physiology of the liver. I think this is just kind of a final wrap-up of this. What does the liver really do? We talked about how the blood goes in from two different directions, how it leaves from one, how it filters its way through all of through the hepatic cells, and it does many things. Not only does it regulate a lot of our metabolism, it creates our albumin, makes globulins for us. It makes most of our blood clotting proteins, and so forth. It helps regulate our blood by making the blood clotting factors. It also plays a role in breaking down the hemoglobin, because remember, blood cells only live 120 days, and so that means you've got to be breaking down about 3 million red cells a minute throughout your life, and you got to do something with that hemoglobin. We don't want to lose it and have to make it again, so we recycle it. We'll talk about that, because basically the breakdown of hemoglobin is what we're talking about when we're talking about making bile. Bile is this green stained stuff, and indeed the thing that stains it green is breakdown products of the hemoglobin. So, regulate, what all does the liver regulate? This is why everybody in this room, I'm sure, has a very good liver, because we have a lot of liver to spare. So, even if you drink a lot and you don't eat much food, your liver will last a long, long time. Indeed, cirrhosis and destruction of the liver is a disease of older people, usually. In the Navy, we almost had no cirrhosis, even though a lot of sailors and people in the Navy drank a lot, and that's because they ate good food. In the Navy, you got served meals 3 times a day on every ship and in every port. And so the problem with alcoholic liver disease is if you don't do anything but drink alcohol. If you don't drink anything, if you don't ever eat any good food and you only eat alcohol, that'll rot your liver away pretty good. That's called alcoholic cirrhosis. Anyway, and you have to lose most all of your liver before you really start having troubles with it. So that's a good thing. The liver regulates the composition of the circulating blood, the nutrients. It breaks down waste products. The liver stores nutrients. Remember, we've always been talking about this one thing we try to store up before we go run a marathon, which is called what? Carbohydrate. Yeah, what? It's a form of carbohydrate called glycogen, right? Yeah. So that's one of the things that's made in the liver here and stored in the liver. And then, of course, our liver deactivates a lot of our drugs. That's a good thing and a bad thing. That's one of the, just as a sidelight, you know, Tylenol or acetaminophen can destroy your liver because it is totally broken down in the liver, and if you take too much of it, it can make you pretty sick. What is the, let's talk about circulating blood here a minute. The blood that's coming into the liver from the hepatic portal system, let's talk about it for a minute and give you pictures of it. I really didn't show you these before. But this is high nutrient containing blood that just came from the bowel. It came from the colon, it came from the small intestine, it came from the duodenum, it comes from the stomach wall as well. And then it all collects into the portal vein, the hepatic portal vein, and goes to the liver. The liver then extracts all those nutrients and stuff out of the blood, and then eventually it gets into, it percolates through the liver and leaves the portal system, basically, and enters through those hepatic veins. Remember, the ones that come in from all sides and go into the vena cava as blood is leaving the liver. So, I think it's just important to know that the liver has a great deal of capacity to correct nutritional deficiencies. It sort of selects what it wants out of the blood that's coming from your intestines and then makes it into whatever it wants to. So the liver plays a huge role in almost all of our chemical processes, making carbohydrates, lipids, amino acids, waste product removal, vitamin storage, mineral storage, drug inactivation. I think it's just clear to say that the liver is really a metabolic powerhouse for you and takes care of all those different things. Another thing about the liver is it's full of blood, and it has a lot of blood flowing through it all the time, huge amounts of blood. Remember, it's coming from 2 different sources. It's coming from the portal vein, hepatic portal vein system, and it's also coming from the hepatic artery proper. But this is a pretty cool number here if you think about it. Of all of the blood pumped by your heart, about 25% of it is going to your liver. Now, just so you know, about another 25% of it is going to your kidneys. Those are the 2 metabolic organs that are just really active in our abdomen. And so, as a result, when they get hit in a car accident or something, both of those 2, both the kidneys and the liver, bleed like hell. And those are very serious injuries. How does the liver work in terms of hematologic regulation, your blood regulation? Well, phagocytosis goes through and eats up most anything that's in the blood that shouldn't be there. We manufacture all of our plasma proteins. Those are mostly albumins and globulins. We talked about those yet? Maybe that comes next chapter. Removes antibodies that have been used up. It takes out toxins, and it synthesizes bile. We'll talk about bile here a good bit more in just a bit. What does bile do? Bile is this green liquid. How many of you have ever vomited bile? Because usually what happens when you're really sick and you vomit, the first time you vomit, you're kind of vomiting what was in your stomach, and then you vomit again, and then it starts tasting really lousy, and then you vomit a third or fourth time, and it's green, and it's really awful tasting. Well, that green stuff is the stuff you've just vomited up out of your duodenum, and it's got a lot of bile in it, and that's what makes it green, and that's what makes it taste so awful, is the bile. Remember that lipids aren't really water soluble, but yet they were being acted upon by those lingual lipases and sort of started to break down in the stomach. It's also been mushed up a lot in the stomach, and this creates these drops of liquids. So like if you eat a bag of popcorn, which has got lots of grease and oil on it, those are going to be droplets of oil down in your stomach and going on into your duodenum. The pancreatic lipase, it's also going to make, the pancreas is going to make a bunch more lipase. But the thing about the pancreatic lipase and the lipids from the stomach is they're in big droplets. And you can't, it's a droplet. And you got to get it mushed up into smaller things. And so that's what the bile really does more than anything else for us in terms of digesting fats, is it emulsifies it. Now, what does that mean? Well, that means, think about your Italian dressing. And it's sitting there on the table and it's separated out, and there's oil on the top and vinegar on the bottom, right? And it's in big droplets, and you shake it once, and it forms some big droplets of oil. You can see them in there. But if you take it and really, really shake it, it becomes emulsified. It becomes cloudy because it breaks those big droplets of fat up into little bitty droplets. And the good thing about having little bitty droplets is now it's a whole lot easier for those lipase molecules to get at the fat. And so we really need to emulsify our fat before we can really digest it. So that's probably the most important thing that bile salts do for us, is they emulsify the fat. Another way to look at that is like when you do your laundry, what does soap really do? What does that laundry detergent really do that you pour in your washing machine?
Surface tension. Breaks up surface.
Does surface, yeah, changes the surface tension, breaks up what? It breaks up all the fatty oil and stuff that's in your clothes, so if you're a mechanic and you get oil and stuff, it's not going to come out of there with just water. But if you put soap in there and the soap mixes in with it, it emulsifies that fat, that oil, and it can come out of your clothes. So basically that's the same thing that this bile is doing with the stuff that's in your intestines. Okay, let's go back to the gallbladder for a minute. Anybody in here had their gallbladder out? Well, gallbladder is just a blind pouch. I drew pictures of it the other day. And I'll just tell you the story like I told to probably 1,200 people that I took their gallbladders out. Because it was a very common operation. And I'm sure it sent all my kids to college. So the gallbladder is near and dear to my heart, sort of, so to speak, at least near and dear to my wallet. All right. So here's the story, Mrs. Jones. Mrs. Jones, you came in the hospital the other night and you were really sick, weren't you? She said, oh, yes. Oh, it was terrible, doctor. Where did it hurt? Oh, it hurt back here in my back. And hurt in my tummy, and I was just throwing up and throwing up. What did you have to eat that night? Well, we went out to a pizza place, and we had a pizza. It was really good. And when did the pain start? Well, it was about 2 hours after I had this cheese pizza with pepperoni on it. Okay. And then how long did the pain last? Oh, gosh, it lasted for 6 or 8 hours. And then what happened? Well, it just kind of went away. But then I went to the doctor the next day, and he said, well, it sounds like you're having a gallbladder attack. And he sent me over to get an ultrasound of my gallbladder. And they put this greasy stuff on my tummy, and they took pictures of my gallbladder using sound waves, and it showed that I had a bunch of stones in my gallbladder. And so then he sent me to you. He said, you could probably fix it. And I said, okay. Well, here's the deal. Here's how it works. Remember that your bile is all made up here in your liver, and it filters, it comes down through these hepatic ducts. This is the right and left common hepatic duct. Comes into the common hepatic duct. And then it's heading on down here to dump into the duodenum. But between your meals, what we normally do is we kind of close off this little valve down here that I just showed you a picture of a minute ago, where it goes into the duodenum. It really kind of circles around and back and hooks in on this side, but anyway. This little valve kind of closes off, and your bile pours out here into your gallbladder, and your gallbladder fills up like that. And then when you eat a meal, and you've got a bunch of food up here in your stomach, especially if it's fatty food, as that fatty food starts being released through your pylorus, there are signals released from the wall of your duodenum. There's a special enzyme there, hormone, that is called cholecystokinin, right? CCP, whatever, yeah. And that cholecystokinin is sort of like when it gets released, it's sort of saying, hey, Mr. Gallbladder, we've got some fatty food down here. We need some bile to mix with it to emulsify it up. And so what happens then, because this food's here in your duodenum, is this little muscle relaxes right here, and your gallbladder then takes and squeezes down and pushes the bile on down in to mix with your food. And that works pretty good. The problem is, while it sits there, and it's been sitting there for years and years in you, Mrs. Jones, probably ever since you had your baby, because we know that pregnancy is a very major risk factor when it comes to forming gallstones. And you've had these stones, and they've been just rolling around in here, and they haven't been giving you a bit of problem. But then the other night, one of those stones got caught right up here in the mouth of your gallbladder, in the neck of your gallbladder right there. And so now you eat that pizza, and it comes down here, and the cholecystokinin gets released, and it says, hey, Mr. Gallbladder, squeeze down. And your gallbladder tries to squeeze down, but it can't get out of the gallbladder because it's blocked off by that stone. And that stone sat there, and your gallbladder squeezed against it and squeezed against it. And if it kept doing that long enough, it would get infected, and you'd get really sick from it. But yours finally relaxed. The stone probably fell out. It's still in there, just rolling around, and it could stay there for a long time. You may not have another attack for a week. You may not have another attack for 6 months. But you might get really, really sick in the meantime. It's hard to know, so I would recommend to you that you have your gallbladder taken out. And we would go in through the laparoscope, through little belly button incisions and little half-inch long incisions, and basically we would clamp off the gallbladder here with some clips, clamp it off there and clamp it off there, cut it, and then get the blood vessels that go to the gallbladder and just kind of roll it out and kind of cut it out using a little electric cautery, and take the gallbladder and all the stones out. And you might say, well, gosh, Doc, what's going to happen when you've got my gallbladder out? I'm not going to be able to squirt those 3 big squirts of bile in every day when I eat my 3 meals, right? And the answer is, that's right, you're not going to be able to, but we have lots of extra built into the system. So you will still be able to digest your food perfectly well. You'll have plenty of bile, and it will just dribble in there all day long. It's not a problem. And I can honestly say that I never really had a patient come back to me later and say, I just can't digest my fat normally now that I don't have my gallbladder. It doesn't work that way. Remember, all the gallbladder is kind of a storage facility. It doesn't make you make any more bile or less, but those stones need to come out of there. So that's kind of the way it works. Well, that's a long story to get to this couple things here. While the bile is sitting in your gallbladder between meals, though, it becomes very concentrated. So it goes from kind of a pale green to almost a dark, dark black. And indeed, if it stays there long enough and you have enough cholesterol in it, it crystallizes out and forms these stones. Bile stones are almost always cholesterol-based, as opposed to kidney stones, which are usually calcium-based. But anyway, so it lives right over here. The pain is oftentimes felt in the back. And let's just keep on going here. This is silly, a fundus, a body, and a neck. The neck is the important part, probably because that's where the stones get caught trying to get out. The cystic duct is the name of this bile, the gallbladder duct. So this right here that we cut here is the cystic duct. And where the cystic duct hooks up with the common hepatic duct, from this point forward, it's called the common bile duct. So I think I've said all of this that needs to be said. I'll just leave it at that. The physiology of the gallbladder. If the gallbladder is really full, it can contain up to 70 cc's of bile. So it'll get about that big and hold, close to 100 cc's. The water gets absorbed out of the bile. That's why it gets so much thicker. And as it becomes concentrated enough, it can crystallize and form stones. Okay. I think I've explained all of this. These regulatory mechanisms center around the duodenum because remember the duodenum is where CCK is released. The distal stomach is where gastrin is released. And the duodenum is also where secretin is released. Those are kind of the main hormones you need to know about. I think I've said enough about this stuff here too. And that too. Here's the ones you ought to know a little bit about at least. The main ones are secretin, CCK, GIP, which is gastric inhibitory peptide, VIP, which is vasoactive intestinal peptide, which makes your guts go faster. Gastrin we talked about, and I have no idea what enterocrinin is. I'm sure it's important, but we never talked about it back in the day. And I've talked about these other guys, so I'm going to kind of move along here. Notice that food in the stomach up here in this diagram causes the release of gastrin. It's also caused by the walls of the stomach being stretched and full. Chyme in the duodenum, which is going to be acidy, is going to cause VIP, secretin, CCK, and GIP all to be released. When it starts arriving on down in the duodenum, in the jejunum rather, that's really where things start getting absorbed into your body and taken on board. You need to understand these hormones that I just mentioned. Intestinal absorption takes about 5 hours from materials that pass from your duodenum to the end of your ileum. Now, obviously, the end of your ileum is where your colon starts, so it goes into your large intestine in about 5 hours. So that's about 20 feet that it travels through all these loops of bowel, and it takes about 5 hours, so it's not any big race. Although many of you have probably had diarrhea where you ate a meal and it irritated you somehow, and 30 minutes later you were in the toilet and it was all coming out, man. And that does happen if something's irritating the inside of your intestinal tract. Things can move very quickly through there. When we get out of the ileum, so it goes duodenum, real short, jejunum, pretty long, ileum, pretty long, then it goes into the large intestine at the ileocecal valve. When you get to the end of the ileum, it enters into the cecum, which is the first part of the large intestine, It's where the appendix lives, and then it works its way around the colon. And it says it's horseshoe shaped. That's being generous. This is important, I think. My faculty, when I was doing surgery, would always say, "Now, Dr. Sessions, what's the function of the colon?" And I would say, "Well, sir," I wanted to say for the 20th time, the colon only does two things for us. Number one, it absorbs water back out of the guts, the bowel, and it stores our feces so that we can go to the bathroom in a socially acceptable manner. Now, as we've talked about some of the animals that we deal with in the lab, like the rats and fish and things, they're not very socially acceptable. They just poop whenever they want to. They pee whenever they want to. They don't have to store stuff up in their bladder to get to the bathroom. They just let it go whenever they want. Well, that really is a function in humans of the colon. There's also some vitamins that are absorbed in the colon. We'll talk about them, but that's pretty darn minor. Let's talk about the parts of the large intestine. The cecum is that little pouch over there in the right lower quadrant. The cecum is a really big deal in the rats. Did you guys remember that cecum? It was a huge pouchy thing over there. So here comes the small intestine. After traveling its 20 feet or so, it enters into this the colon, and the colon goes like this, and so this is the cecum right here. The very first portion, it's kind of a little blind pouch, but like I said, in rats, it's like this big, really huge. Chickens, it's really big too. The other thing that hangs off the cecum down here is the appendix right here. There's this little thing that can get clogged up and get infected and causes appendicitis. So this is the cecum. This is the right colon. It's also called the ascending colon because it's going up in the abdomen. And then we get up here to this flexure, and we call this flexure the hepatic flexure. Or we call it the right colonic flexure because it's on the right side of the body. Then we go across, and it's called the transverse colon. And then it gets over here to this flexure, and this is called the splenic flexure. Guess what? The spleen lives over here, and the liver lives over there. That's where they get their names. This is also called the left colonic flexure. Then it comes down here. This is called the left colon, or it's called the descending colon. And by the time it gets over here, the stool is starting to become somewhat solid. And then it enters into this loopy part here, which is called the sigmoid colon. It's called the sigmoid colon because it's shaped like an S. And S, sigmoid is the Greek letter, I think, for S, right? You Greeks in the crowd. And then finally, it kind of leaves out of the peritoneum right down here. And this lowest 10 centimeters or so is the rectum. It's named the rectum because it's straight. Remember, rectus abdominis and rectus muscles in our eye and all that stuff. Pretty interesting, isn't it? Yeah. Okay, so there you go. And cecum, nothing much to it. The appendix is also called the vermiform appendix. You remember the vermiform part of the cerebellum? Or that little strip in the middle of the cerebellum between the right lobe and the cerebellum and the left lobe called the vermiform lobe. Same thing. Vermiform means finger, shaped like a finger. Anyway, it's mostly just full of lymphoid nodules, so we like to think that the appendix is actually a lymphoid organ. It's supposed to fight infection, but the fact is in humans it's so little it really doesn't do much of anything except get clogged up with little doo-doo balls and then cause appendicitis and rupture and get you really sick. not to trivialize things, but just for you all to realize that appendicitis was not even described as a disease until 1916. 1916, that's 100 years ago this year, that the first doctors ever knew that appendicitis was caused by this little thing hanging off the lower part of the colon. And the reason was because surgery was so dangerous prior to that, before the invention of anesthetic drugs and stuff, and being able to put people to sleep to do surgery on them. It was just so dangerous that it was never done until people were absolutely dying. And by the time they would operate on people with appendicitis in those days, it was usually ruptured appendicitis. It was usually just spread throughout their abdomen, and it was really hard to figure out where it came from. So they didn't figure out where it came from quite a long time. In my career, I only saw one patient ever die of appendicitis. It was a drug abuser who was shooting everything in the world and kind of didn't come in for like 2 weeks with his ruptured appendix. And you know, now compared to back then, it was 100% fatal prior to 1916. 100% of people that got appendicitis before 1916 died of it. Think of that. How many of you have had your appendix out? One. My daughter had hers out. Okay, well, there you go. Nonetheless, what now seems like a trivial little deal used to kill everybody. You're lucky you made it. You were lucky you weren't born 100 years ago.
Mine ruptured too.
Yeah. So anyway, the colon is kind of interesting because it has these little pouches out the side of it. They're called haustra. I think that's we'll show them to you, but they don't really mean too much. They allow the colon to get bigger as it fills up. The other thing about the muscle of the colon, the longitudinal layer of muscle that in all the other bowel goes all the way around the bowel as it goes downstream. In the colon, it has consolidated itself into 3 little strips. And those 3 little strips are called the tinea coli. And they show them in your book in several of the diagrams. They run along the outer surface of the colon, and you can see them very easily at surgery. And that's one way you can look at it, and immediately you know this isn't small bowel. This is colon, because the colon has these 3 strips, and I'll show it to you in a minute. So between the tinea coli, between these strips, the colon kind of bulges out. And it's those bulges that are called the haustra. Let me show you a picture here in a minute. This colon has serosa, like all the rest of it. And I think I've said all this stuff right here already. There it is. Blood supply. Where does the bowel get its blood supply? Of course, the small bowel gets all of its blood from the superior mesenteric artery. Remember the SMA, that's the first of the 3 unpaired arteries. I'm sorry, the second of the unpaired arteries. The colon, the lower part of the colon gets its blood through the inferior mesenteric artery. And remember, all of the blood that's collected from the bowels gets pushed back up through the superior mesenteric and inferior mesenteric veins, which then become part of the hepatic portal vein and go to the liver. So blood doesn't go the way you might think it would. It goes back to the liver. Rectum is that last little piece. The rectum is the part that when it gets stretched and it fills up, you get signals to your brain that say, hey man, you need to go find a toilet. That's a kind of an involuntary reflex almost. So usually there's very little in the rectum at all, but when it does start to fill, you get the feeling that and that triggers the urge to defecate. The anal canal is the very last inch or 2. It's where the hemorrhoids live, and it's where the anal muscles live that hold everything in. And the anus is the outside. Just so you know, the anus is kind of like your lips. You know how you have this change in the surface, like on your lips. It's going from skin on the outside to mucous membrane on the inside. Same thing goes on at the other end of it as well. We have 2 sphincters, 2 anal sphincters. This is an important point that you should know. there's an internal anal sphincter. The internal anal sphincter is not under voluntary control. This is the one that keeps your butt closed all the time, so that you don't soil yourself in the middle of the night, and so that you don't have to wear diapers all the time. The external anal sphincter is it's a skeletal muscle. It's the one on the outside, and it's the one you can hold if you really need to. It is under voluntary control, and it's the one most on the outside. My rectal surgery teacher, a really smart guy, he used to just always say that the only function of the external anal sphincter was to keep the flies out. It doesn't really do any good for keeping stuff in, but you can really close things up back there and keep the flies out if you want to. With it. Here's these little haustra things. See these kind of bulges out the side, and these are those tinea coli, where the muscle, the longitudinal muscle layer, instead of extending all the way around the colon, just kind of coalesces into three little strips. One. The other two are around and back. Okay. Here's the ileocecal valve, which is a valve that keeps the stuff in your ileum until it's ready to receive it here in your colon. If it poured in too fast into your colon, that would put too much hypertonic stuff in there. It would probably give you diarrhea really bad. You'd be running for the toilet. I think I've talked about everything else, but anyway, here's the superior mesenteric artery, the big one that goes to your whole bowel, small bowel, as well as to the ascending and transverse colon. And the only part of the colon that gets blood from the inferior mesenteric artery, which is the second one here, is the descending colon and the sigmoid colon in the upper part of the rectum. Okay. But notice that the blood, when it goes back, instead of going straight to the inferior vena cava like you might think it would, it takes and turns and goes up this way, and all the blood from the small intestine goes up this way, mixes in with this becomes called the superior mesenteric vein. This is called the superior mesenteric, or the inferior mesenteric vein, because it runs along the inferior mesenteric artery. And these meet together to form the hepatic portal vein that then goes to the liver, remember? And the hepatic portal vein is a really big vein. It's bigger than my little finger. I operated on it a few times, and it's pretty scary because it's really big and it bleeds a lot. Okay, here's the ileocecal valve inside. If you cut the cecum open and look at it, you can see this ileocecal valve. This is where the ileum dumps into the cecum, the colon, and then here's the appendix hanging off the end of it. This is a cross-section down through the anus, and this is the external anal sphincter out here. This is the one that's under your control but really doesn't do all that much for you. This is the one that really matters, the internal anal sphincter right here, and it's the one that keeps your anus closed off all the time. Leave it at that. What does the colon look like on the inside? Well, it doesn't really have that many villi because it's not really absorbing that much. It's just absorbing some water. Lots of mucus cells to keep things sliding on through. And it's pretty characteristic looking. When you look at a slide or two of the colon, you'll recognize it quite easily. There's no enzymes in the colon. There's none of those brush border enzymes that help you absorb stuff. And I think I'll just kind of leave it at that. Once again, this diagram here describes this business of the tinea coli. So this, the longitudinal layer is here, and then the circular layer, I got this, that doesn't look right. Because it's the longitudinal area, a layer that becomes the tinea. I think they've mislabeled that right there. Anyway, this is the circular layer right here that goes around and around the colon, which is what they're illustrating there, but I don't know. There's what it looks like. Lots of goblet cells. Like I said, less than 10% of all your nutrition gets absorbed in the colon. Mostly it just absorbs water. and it prepares the fecal material for ejection, so to speak. Most of the contents of your bowel, once it leaves your stomach until it goes into your colon, is sterile. There are no bacteria living in it. The acid in your stomach killed off all the bacteria. So most of the contents of your bowel are sterile. Once it starts sitting in the colon for a while, because you really never completely empty it out, and there's plenty of colon bacteria, it becomes full of bacteria again. There are some vitamins that are produced by the bacteria that live in your colon, like E. coli, which we have 10 to the 6th of, lots, 10 zillions of them, and that's important. Three vitamins that are produced in the large intestine by the bacteria are vitamin K, biotin, which is a water-soluble vitamin, and pantothenic acid. I don't worry much about those. Just know that there are some vitamins that are very important. The one that's really important here is vitamin K, because vitamin K is needed by the liver in order to for your blood to clot. Okay, so you see all these ads on TV these days for these new Eliquis and some other one that are new forms of blood thinner that they think are safer. We've always put people on what's called Coumadin. Coumadin is a medicine that prevented the formation of the clotting factors. And if somebody was on Coumadin and they came in bleeding from something, and you needed to reverse the Coumadin right away to get them to stop bleeding, you would just give them a shot of vitamin K, and within about 10 minutes they were clotting normally, which is kind of a good thing. The problem with this Eliquis and the other one whose name I can't remember, but I know there's some massive class action suit going against them right now, because a bunch of people have bled to death from these new forms of blood thinners. And the reason is because there is no reversing agents. So if they come in bleeding from something else, you know, a bleeding ulcer or any bleeding into their brain, a stroke, they can't stop it. And it takes like 3 weeks to get out of your system. So I don't know. I know Arnold Palmer's selling it, and who's that other guy with him, the comedian? Kevin Nealon. NASCAR driver. You guys don't watch much TV, do you? Yeah. Just keep studying your A&P. That's good. Anyway, those medicines, I think that it's going to be quite a while before they really are proven to be better. Here's the thing I do want you to know, though, is that one of the things these bacteria that in your colon do is they break down part of the breakdown products of bilirubin, and part of the bilirubin is your hemoglobin. Remember, and if you remember, as we recycled our hemoglobin, we converted into urobilinogen and stercobilinogen. Remember that? Does that ring any bells? And the urobilinogen is water soluble, and so it goes out in our urine, and that is what it's urobilinogen is what makes our urine yellow. Okay, now, I don't know, maybe you guys don't ever look at your urine, but us guys usually see it, so we know it's yellow, and that's what makes it yellow is urobilinogen. It's a breakdown product of bile and a breakdown product of hemoglobin. Now, we also put some of that urobilinogen into the colon, and then the colon breaks it down into some of these stercobilinogens down, and then it gets reabsorbed. Some comes back into our body, and some stays in our stool. And indeed, it's these stercobilinogens that is what makes our stool brown. Okay, so all of this comes from hemoglobin. All these excretory products that are colored somewhat brown come from the hemoglobin. Isn't that interesting? Wow. some gases that are made down there. Hydrogen sulfide gives gas that rotten egg color or odor. I always thought that was caused by eating rotten eggs myself, but what did I know? Flatus is an intestinal gas. You know, people used to think that the reason that we farted, that we made gas, was that we had these bacteria living in our colon that manufactured gas, okay? But the truth of the matter is, that's only true to a very tiny, small amount. About 95% of all the air that you fart out your butt is air you swallowed through your mouth, okay? We swallow a lot of air. A lot of us do it on purpose. A lot of us don't think much about it. We drink a Coca-Cola, and it has lots of carbon dioxide, and sometimes we belch it up, but a lot of that goes on through us. And so this talks about making gas from these bacteria. I think that's a pretty minor deal, just so you know. The last disgusting thing I'll talk about is the movements of the large intestine. I talked to you earlier about the gastroileal. When you ate a big meal and your stomach stretched, it sends signals down to your ileum that, hey, time to move things on through. Gastroenteric, same thing. The colon has peristaltic waves that move through it, but clearly it doesn't happen very often. I mean, we don't move our bowels, but once or twice a day at the most. And if it was just regular peristalsis, we'd be moving our bowels every 20 minutes if it worked that way. But it really doesn't. The haustra, these segmentation things that move the contents of the colon back and forth a little bit to allow the water to get reabsorbed better. But the one that I want you to understand a little bit here, and you should read about this in your book, it's called mass movements, which is different. That's only found in the colon. And the other one is this thing called the defecation reflex. And I know that you've all felt this. I mean, you just sort of sitting around, and then suddenly you get this, whoa, wow, I need to go find a bathroom kind of feeling. And that's because your rectum, a little stuff moved down into your rectum, stretched your rectum a little bit. It sends messages to your brain, and then these stretch receptors in the rectum get stimulated, and lo and behold, we got to go. I'll let you read this over in the book. It's not tough, but this is what happens. It all depends on some distension of the rectum. Once you get it going, though, once you get these mass movements going, that's what they're called, mass movement. In other words, your colon starts doing this, and it sort of moves everything on out. And my dad was from that generation that used to keep track of all their bowel movements. Well, today I had one that was 8 inches long, and I had another one that was 6 inches long, and it was about this big around, and it was, it was light brown colored. And he would write all these things down to take them in and talk to his doctor, and I'm sure his doctor went, oh, God. But just think about it for a minute. Next time you have a really big bowel movement, and think that, maybe that much of your colon just emptied all at once. That's the way it usually works. I mean, you get these mass movements going, and they can literally empty half of your colon, from all the way up at your transverse colon out. In one fell swoop, out it comes. Kind of nice. Usually feels pretty good. Anyway. We have to intentionally open our external sphincter. Remember, that's the one that's under our conscious control. The internal sphincter is going to open on its own and allow this movement to happen. Let's just talk for just a second about digestion. We have this next chapter that we'll talk about it in detail called metabolism. We need lots of things to make ourselves go every day. Carbohydrates, proteins, lipids, water, electrolytes, which is the salts, the sodium chloride and calcium and so forth, and vitamins, which we just need tiny, tiny amounts our digestive system handles all of these things differently. The biggest ones, the big proteins, the big lipids, they have to be broken down quite a bit before we can actually even absorb them into our bodies. And they may require special transport even. This is just kind of an overview of that, and it's very complicated, and I'm not going to go over it with you here now. But just so you know that, here's some carbohydrates, here's lipids, here's proteins. They're all handled somewhat differently. But I just wanted to talk to you about water for a minute. We can't actively absorb water. We don't have any water pumps that pump the water into us. The only way the water gets into our body is by osmosis. That's the way it comes into the cells and so forth. So it requires us having a somewhat osmolarity in our body so that water wants to come in. We obviously want water to come in because we want to have enough water to come in not only to keep us going good, but also to make urine, because we need to make urine in order to process and get rid of all the waste products out with the urine. And so we have to make a certain amount of urine every day to keep it all working. This is the slide that I find really interesting to discuss at this point. And please just listen to me and then look this over in the book. We normally eat or drink about 2 liters a day, okay? So in terms of food and water, we drink about 2 liters a day. This is 500 cc's, so that's basically 4 of these things. Now, I know a lot of y'all can't go anywhere without your damn water bottles, and you just have to be drinking stuff all the time. The simple fact is, you really don't need that much water unless you just like to go to the bathroom a lot. But nonetheless, there's 2,000 cc's a day is plenty normal. Saliva, we make another 1,500 cc's of saliva a day. So coming down our esophagus, we've got about 5,000 cc's once we add in another 1,500 milliliters of gastric secretions. So the wall of our stomach is pouring another 1.5 liters into our stomach. And then as we come on in here, which I could read these numbers better, it looks like the liver makes another 1,000 and pours that in. The pancreas makes about 1,000 cc's of pancreatic juice a day and pours that in. The intestinal wall of the jejunum and the duodenum and the ileum makes another 2,000 cc's a day. And so you might think, wow, that is a tremendous amount of fluid that we've got in our bowel, and what are we going to do? We're going to just pass all that through? I guarantee you none of you go make 5 liters of stool a day. But so that what that means is that we then have to reabsorb lots and lots of the water that we took in, and that our bowel and liver and pancreas and so forth dumped in there. By the time we get down to the ileocecal valve and goes into the large intestine, there's usually about 1,200 cc's a day that passes through there. In other words, we've already absorbed 4 liters or so of fluid back into our body. From there, 1,200 cc's, it goes through the colon. The colon mucus is about another 200 cc's a day. But all of this fluid is being reabsorbed back out through the wall of the colon. And by the time we get down to the very bottom, we usually make about 150 cc's of feces a day. So, the point I would make from this is that our intestinal tract is an incredible tool for not only processing the stuff we put in it, but also it makes a lot of solutions that it pours in to mix with the food to break them down properly, and then it reabsorbs everything back into our body that we don't want to lose. Those are pretty big numbers. We're going to do a whole chapter on fluid electrolyte balance here soon, and I think you'll be amazed that these numbers here are bigger than almost all the other numbers that we deal with in terms of fluid. How much we breathe out, how much we urinate out, how much we sweat out, so forth. These numbers are huge. Our bowel's really kind of cool. I'm not going to talk about this. Talking about calcium down here. You guys have talked about calcium. We're going to talk about it some more. Remember parathyroid hormone, calcitriol, all those good things. And I think that's the end. Look at that. 205 out of 205. Wow. The longest chapter in the book. Okay, so we're going to give me a few minutes. Spec, why don't you guys come in about 20 till. So give me 30 minutes to finish setting up over there. Melissa's, I think, is going to help me. And come on in about 20 till. I'll meet you in the hallway, and we'll run through the practical. And then on Tuesday, we will do the chapter on metabolism. As I've told you before, it's one of those chapters that I'll just talk about what I talk about, and that's kind of what you got to know. But the chapter is pretty long and complicated in the book, but we'll trim it down quite a bit because I think we just have to. Okay? Questions? Comments? Okay. Those, my 231 class took their very first ever practical exam in their life today, and it's always such a heartbreaker. You know, it's so sad, but they all kept saying the questions just weren't very clear. And I said, what? Yes.
So there was this was the one of the questions. But you said this is not sure. You're not sure about this.
Well, I know the longitudinal layer is on the outside, and the circular layer is on the inside. See in this diagram? The circular layer is on the outside, right there. That's not right. So they got it mislabeled.
Oh, so the arrow was pointing at this red layer on the practical, so
I don't remember.